Hello, everyone. Okay, let's get going. Thank you very much. Welcome to this conference. It's an important time. Thanks for braving the heat. Very good. I understand the climate conference was nearly cancelled because of the heat, which would have been ironic, but it went ahead. Welcome to IPPR's State of Health and Care Conference. For those who don't know me, I'm Victor Adibuwale. I'm the chair of IPPR's trustees. I think it's my first outing, public outing. So I'm happy to admit that I am the chair of IPPR, and I'm having a great time. We've got a really packed schedule today, 3 keynote speeches, 3 panel discussions, followed by a drinks reception, which I won't be at because I've got to go and do some other work. So I get to do the work, but I don't get the drinks. So yeah, that's IPPR for you. In particularly, can I just start by saying a big thank you to everyone that's battled through the heat. That's you guys. Remember to stay hydrated. Water, that is. A warm thank you to the founding members of the IPPR Centre for Health and Prosperity. As I've often said, there is no wealth without health, and they are AbbVie, the British Heart Foundation, Gilead, Haleon, MSD and Sandoz. Thank you very much for your support. Your support has made this possible, so thank you very much. When we were last held our State of Health and Care Conference, we were in different times. Since then, a lot's happened, not least our 7th Health Secretary. You know, he's going to turn up. He's still the Health Secretary. We had a 10-year health plan, the abolition of NHS England, ICBs merging across England, you know, a lot of restructuring has occurred. And of course, we will be having a new Prime Minister. So quite a lot's happened. In some areas, we've seen some genuine progress, some green shoots. The elective waiting lists are falling. Ambulances arriving faster, and after years of decline, public satisfaction with the NHS is just beginning to recover, and the government has passed landmark legislation to end smoking for good, which is great. These things do matter, and they're worth acknowledging. But if we're honest, too much stubbornly remains the same. Social care, despite the Casey Commission being up and running, is still kind of unreformed. Has anybody given evidence to the Casey review? Stick your hands up if you have. Oh wow, you'll be popular at parties. Hello, that's very good. That's great. Social care remains pretty much the same, to be honest. The queues for emergency care waits remain dangerously long. Data from the Royal College of Emergency Medicine shows that there are almost 16,000 excess deaths last year due to long waits. And working in the NHS isn't getting any easier either. Around a third of NHS staff say they always or often feel burnt out by their work. There are serious scandals. Yesterday, in fact, the Nottingham scandal, which I thought was truly shocking, was exposed to us all, whether these scandals happen whether in maternity or in mental health. They keep coming. For many people working in health and care right now, the honest feeling is, here we go again. Another reorganisation, more change from the top, but with not enough clear sense of what it all adds up to. We should acknowledge that. It's tough. It's really tough out there. And on the question that sits above all this, is the country actually getting healthier? Well, according to the Health Foundation, the answer is it depends on who you are and where you are. And it's certainly not getting healthier fast enough. And as I say, not for everyone. In our poorest communities, people continue to live decades fewer in good health than those in the wealthiest. That gap isn't an accident, it's baked in From the moment a child is born, it compounds through working life and it persists into old age. That is the story of health across the life course, and it's the thread that's running through everything we're doing today. We will, of course, talk about the NHS today, but one of the things IPPR keeps coming back to is this. Good health is not mainly made in hospitals and GP surgeries. It's made in homes, schools, workplaces and communities. The NHS is essential, but it can't do this alone. So across our three panels today on children and young people, on health in working life, and on healthy ageing, we want to push beyond the healthcare system and ask, what does a genuine whole of government, whole of society approach to health look like? What does it take to build a country that is not just better at treating illness, I nearly said creating illness, treating illness, but genuinely preventing it at all stages of life? Those are the questions we want to explore with you today. In a minute, we'll hear from Sir Jim Mackey. Unfortunately, he's stuck in the northeast, so he's on screen. He's stuck in the northeast because of the weather and the infrequent train service. But Jim is someone who has taken on one of the most demanding leadership roles in public life at an extraordinary moment for the service for the NHS. And after Jim, I'll get off the stage and we'll have our first panel on children and young people's health, which is going to be chaired by Avni. Is that right? Yes? Okay. After lunch, we've got Stuart Andrew MP, Shadow Secretary of State for Health and Social Care, so nobody can say we're not balanced. He'll set out his early thinking on the Conservatives Party's vision for health and care and NHS reform. I hope he does mean reform and not restructuring, because we could do with less of that. Before our panel on health in working age, and then after a short break, we'll have the Right Honourable James Murray, Secretary of State for Health and Social Care, who will deliver the final keynote of the day, followed by our panel and on boosting older health. We'll close with the drinks reception at around 5:30. Please stick around. There'll be a room full of people who care deeply about building a better health and care system, and some of the most useful conversations will probably happen informally in places like those drinks receptions. But for now, I am very pleased, if the technology works, yes, we're ready? Cool. To welcome virtually on stage Sir Jim Mackey, Chief Executive Officer of NHS England. Jim has been Chief Executive of NHS England since 2025, after a very long and distinguished career in the NHS as National Director for Elective Recovery in NHS England, as the Chief Exec of NHS Improvement, and as a Chief Exec of Newcastle upon Tyne Hospital's NHS Foundation Trust and Northumbria Healthcare Foundation Trust. As I've said, due to travel issues, he can't be here, but I thought you'll give him a warm welcome anyway. Hi, Jim.
Hi, Victor. Thanks for that. And then, sorry again for not being able to be there. Very frustrating travel this week because of the weather. I'm going to just talk for 10 minutes or so and basically extend your introduction. Just talk about what we've been doing over the last year or so, some improvements, whilst none of us are where we want to be in terms of the service quality and outcomes that we want to deliver for our population or the environment we want our colleagues to work in. I think we absolutely should acknowledge what the NHS has managed to deliver in this last year. So first of all, just a quick recap of where we were in the spring of last year. First point I would make, I'm in a session the other day in the group for the British Society of Gastroenterologists, and use some slides for that demonstrate we went into COVID with quite a steady decline on all the key metrics. So a lot of our issues often get blamed on the pandemic, the impact of the pandemic. We were off track before then already, and all the evidence generally shows that your ability to recover is driven mainly by your fitness before the event. So the point of that is we can't address our issues until we actually fully understand and acknowledge them first of all. Then at the impact of the pandemic and the struggles to recover, some progress on some things, a bit mixed on others. long period of industrial action, financial troubles, etc. Got us to the point last spring of a really big financial problem going into the year that we've just finished, planning deficit of about 4.5 billion. But on the backdrop of having had to go back to Treasury pretty looks like every year or thereabouts for about 10 years, mid-year, and at one time it looked like that was about £6 or £7 billion. So a big consumer resource at a time when the economy is struggling, lots of international instability, etc. So concern around that, but also making progress on the metrics, but not quickly enough. I think demonstrated in the British Social Attitude Survey, which has been one of the biggest things that has stand out for me about this last few years. We've had a really bad set of results the previous year, and last year it got worse as well. So big shock to the system. And me and other colleagues got involved in this to try and provoke a leadership response to get a hold of this, stabilise, make some improvements, and then start building the foundations for longer term recovery. One of the things, we really struggle at times, I think, to get balancing all of this sort of thing. And I'm very, very aware of this given the Donna Hopkins report yesterday. I don't want anybody to think we are where we are, but I do want us to acknowledge that the NHS did actually make big strides last year on the money, on the key metrics, which we'll discuss in a minute, and as you said earlier on, Victor, to have a reasonable bump in the British Social Attitude Survey in this spring against that background of two terrible years worth of results. The big concern in all that, by the way, from my point of view, is that disconnect, a growing disconnect between the NHS and the population. And our strong belief that the service is owned by us all, and then this is our service, and we survive and thrive with the will and the support of our population. So we really need to be cherishing that and building on it, building our confidence as time goes on. So tricky period. And you and I were at Expo a couple of weeks ago. When I went to Expo last year, you could feel, I think you'll remember, the anxiety in the room on the back of the headcount reduction, the restructure, frankly, what people were going to have to do to manage the money, the worries about all, having to deal with things on multiple fronts, across performance, satisfaction, public confidence, you name it. It was a pretty tricky period. Through the year, that obviously got more complicated with industrial action and other things as well as we went through the year. And at the turn of the year, so remember we had industrial action just before Christmas, just on the back of a big flu spike, and then had to go into winter with a lot of anxiety there, and then that push into the final quarter of the year was really important to us. Even in January and February, delivery against some of the key metrics like the elective standard progress objective was set at 65%, looked beyond us. All the modelling looked beyond us. And then what we saw was across the NHS on a range of things, money, performance, people powering staff experience, work, patient experience, work, bringing neighbourhoods to life, etc. The NHS gradually started to show that we can, on every key issue, we have people who've solved it and made huge progress. And frankly, also destroyed the modelling. So we had people improving, organisations improving so rapidly in the final quarter, it blew all the models out of the water. I think that's a really big point for us, just to land before, I'll come back to it before I finish. And then also going into this year, first year in many years that we've had the ability to plan over a medium-term planning period, which sounds a bit technical, but it gives NHS colleagues to work together to think about improvements over a period of time that can't happen quickly, but can happen if you get organised around it. People pull together, get focused, get the resource in place, and do over a medium term, so 18 months, 2 years, 3 year kind of process. It's felt throughout all of that, going back to your intro, Victor, at times overwhelming, and I honestly would think if anybody's been working in the service through this period and you haven't felt overwhelmed, there's probably something wrong with you. You know, it's felt like we've been having to do 5, 10 years worth of work in a year or 18 months or whatever, and we had to because of that concern about are we at a point where we've damaged confidence so badly we can't get back on our feet, we can't restore the confidence of the population, we can't start doing the things that we need to do long term because we're all caught up so much in the short term looking bullets and crisis of the situation. I think our results in for the year end and through the year show that having largely delivered on the metrics we set out, certainly on the money, certainly on the elective process, some of the big improvements in ambulance response times, the management of winter, mitigating the impact of industrial action, starting to show through in primary care satisfaction and British Social Attitude Survey, has shown that we've had the leadership response we were after. We have got ability across the NHS to deal with all of our challenges, and evidence now that on pretty much every issue colleagues are dealing with it and have improved really dramatically. But this year has to be a year where we'll move through that and into a more sustainable period where we've laid a foundation, we start accelerating. So I'm talking about our big leaps where this year we have to use the evidence for that sort of 6 months or so, understand how organisations made some of these big leaps in improvement and industrialise them. And I'll just talk about a handful of those key priorities. We'll go to chief execs together again next week. We'll talk about this again then. First point would be, nobody would argue that our outpatient model needs to change dramatically. It consumes a huge volume of clinical time. Generally, in my experience, the public are very respectful of it. But if you had the disruption of having to lose a day's work, juggle childcare, other caring responsibilities, etc., for lots of follow-ups. There are different ways of doing that now. And again, if we think about the way we live our lives generally in a more digital, more controlled way where it's more able to fit around our lives, we're absolutely convinced it's a way of using our clinical resource more appropriately and tailoring the service so more fittingly works for the population, for our patient population there as well, and develop more digital access and digital channels as part of that. Second point would be on urgent care. It is generally believed that urgent care, people turn up at ED or an urgent treatment centre, etc., is uncontrollable and largely about beds. It's absolutely not. The vast majority of patients turning up in that setting are amenable to scheduling of appointments. So whether that's a same-day emergency care centre, an urgent treatment centre, a hot clinic, we've got a lot of different dispositions now where we can start bringing order into that system, give people the ability to book appointments themselves through the technology, and protect the service in terms of that very time-sensitive cohort for those who really need immediate attention. So we'll be moving on that through this year as well. Third point would be on neighbourhoods, which is one of those odd things you touched on again, Victor, that really energises people. Nobody argues about whether it's the right thing to do, taking care closer to people's homes, really wrapping around the more vulnerable in society, preventing this distortion that we've got where most care is delivered in hospital, most resources in hospital. We've got lots of people in the wrong parts of the system. But it is actually quite hard to do from where we are now, and it's got to be an all-partner play, health, local government, police, justice system, housing, everybody working together around the population. So this has got to be the year that will turn that from green shoots into really palpable change for the population. And the fourth point I think is really going to help us drive this is really powering up our ability to listen to the population, listen to our colleagues, respond appropriately. Again, going back to the shocking report yesterday, there's an awful lot in that about our inability to listen and tailor services, respond appropriately. So we've just recently appointed a new National Director for Patient Experience. They'll start soon, just go through the approvals processes. We want to really power up as well, based on the back of our resident doctor industrial action work around the 10-point plan. Make this live for everybody who works in the NHS, improve everybody's work and life, but fundamentally make it all more responsive for our population. So it's been a really busy year. There's a lot in those 4 priorities, but we're absolutely also going to have to really lean in on things like, again, go back to the report yesterday, and we've got Baroness Amos's review of the report soon as well. So issues in mental health, other challenges that come our way where we're not where we need to be, rapidly mobilise our response to that. So in maternity, for example, Chief Exec session on Tuesday, we've got nurse directors, medical directors joining us for a session there to move very quickly into an action phase. Because in a lot of these things we hear repeated horrors and failures in the service in lots of ways, a lot of repetition, probably too little action over recent years. Well, we just need to get really crisp and clear about who needs to do what to deliver what we need to do. So if you step back from that, and I just temper this again with, I don't think I've lost the plot. I'm not being delusional about this. I'm not saying that we're in a perfect state, but the NHS has made big improvements in the last year against a very, very complicated backdrop. We need to build confidence on that, try to work with colleagues around the service to build on that, accept and celebrate progress that's been made, whilst understanding we've still got a lot to do. Go back to the point I made earlier on, we'll not get where we need to be at the right pace by small, incremental, marginal changes.
I agree.
Playing the old game better. We have to play a different game, which is where those big reforms around outpatients, urgent care enablements, and our ability to listen to patients and colleagues in the service. That's where the value is. So I feel like I'm rambling now, so I'll stop there. If it's okay with Victor. I'm very happy to take any questions.
Thanks very much, Jim. I've got 3 questions. Hang on. I've got a couple of questions to ask, and then I'm going to throw it out to the audience. First of all, thank you for taking the time. And as I said to you at the NHS ConfedX conference, I agree with you. You know, we have to understand the problem. We have to understand where we're going. I think your priorities make a lot of sense. I just want to ask you a couple of questions. The first one's about NHS England abolition, because you're in a very unusual position. You're leading an organisation through its own abolition, and I'm really interested in how you're going to maintain the grip on performance while that's happening around you, literally while the centre's being dismantled. Something like 23 of the 25 major NHS England priorities, or NHS England statutory duties, for want of another term, are going to go into the centre, and actually responsibility of the Secretary of State, who I'll be talking to later. And a lot of the things you've mentioned in your priorities will require quite a bit of devolution of power. So I just wonder what your thoughts are on how you, I guess, are going to maintain that grip while sort of dismantling and distributing power to the front line, where I think you'd agree it's needed.
Yeah, absolutely. Good question, Victor. And it's really pertinent because we're right in the middle of a lot of these discussions on this work just now. You will know I'm a really big devolver. My belief is the real action on all of this is local. We need national set rules, conditions, the environment for success, the payment mechanisms.
Yeah.
Do things once nationally, that can only be done there. But really, this is about local leadership taking control, ownership, owning its issues, working with colleagues locally and partners locally. So that's it. We're trying to build that system. We just feel very complicated about building it out there, building the rules system, and then through the change process between NHS England and the department, make sure we get the balance right when NHS England is abolished and it goes back into the department. We'll learn from the past and how this has worked before. And one of these really strong messages, listening to colleagues who lived in that world previously, there has to be a degree of operational freedom and control within the departmental system. So we're working through that now. It's going to be constantly defined. One of the first things that we did today, Victor, was about how we manage RIP in this transition. Because none of us have the space to take our eye off the ball for very long. It's very complicated, but I'm confident we've got enough local energy and enough the right people working with us on all this change. The Secretary of State's very actively involved in himself to just try and get the balance right, learning from the past, learning from when they performed well. But there's no question, there's a lot of risk in it. We are surrounded by risk in it.
Oh, yeah.
Yes.
I just want to ask you another question about finances, because as you've made clear, and I think everybody knows, we're not in an era of significant real terms increases for the NHS. That's not going to happen. So if the money's not going to grow, as it once did, where does that leave the service? And I'm particularly interested in what are the choices that we're going to have to make. And I, you know, the NHS has continued to plough on as though those choices weren't that clear. And I'm just wondering what your view of the choices we're going to have to make over the next, you know, actually 1 to 3 years, and how we address that with the public.
Yeah, so again, another good question. So you'll know I was a finance director. Finance. The hardest year in my financial career was in about 2003. I was in FD. I think we had something like 7% real terms growth. It was the hardest year to manage the money. So first point is we do tend to perform better when money's tight, I think. Often when money's not tight, I don't think we've got a good track record of using it as wisely as we could. So that's the first point. Second bit is, I think build on the confidence of last year. You know, this time last year, nobody believed that plans were doable. Partly the operating model changes with financial, which is about £1 billion in the service. It's a huge amount of money through the changes of the operating model. And the choices, again, often get presented as big service configuration choices. And going back to my earlier point, I think we've got some choices around whether we'll continue to see stable people in outpatients who frankly could be using their time better, or would devote that resource to get more new patients seen and a diagnosis, and then start a pathway. So I would say there's more of that kind of choice ahead of us. More standardisation or variation is huge. No matter what you look at, there's huge variation. So how we share good practice better, we help challenge people about where the variation is. We just about do that tomorrow in a range of things.
And do you think the financial incentives and the way those financial incentives operate mean that the rhetoric around neighbourhoods, the rhetoric around choices, actually changes behaviour in, you know, at finance director level?
Not yet. So we started last year through the unbundling of the block to start moving in that direction. And honestly, this is one of the things I would have wanted to go harder, but when we looked at the changes we wanted to make to the financial regime, given the mess we were in, it was just too scary. There was too much risk to do it in a rush. So we've asked the local NHS for requests for additional freedoms on the money, changes to financial flows, etc. We've got a board session coming up where we'll consider some of that. And there's an FD conference next week in Birmingham, which I'll speak at, where we're constantly trying to get examples where we can take an idea and try it, but with the proper risk management around it. I would love a lot more proper incentivization, much more fluidity on the financial flows. But when you look at the overall risk environment that we're in, there's only so much people can cope with. So I think we are limited to a degree, and that will have to build over time.
Okay, let's throw it out. Let's take a couple of questions. I'll take, yes, If you say who you are, keep it really short because I want to get through as many as possible in the time I've got.
Hi, thank you for an interesting contribution there. Jenny Edwards, I chair the People's Health Trusts, and we've supported thousands of organisations in communities in the areas that have the highest health inequalities. We were very excited by the government's huge ambition when it was elected to really cut health inequalities significantly. That's people's length of life and living too many years in ill health. The problem for the communities that we work with is we're not finding the right response from health organisations.
I'm going to hurry you to a question.
So what are you doing to address that enormous ambition, and what message can you give to local health organisations to say they will get those answers if they work with communities? The communities have many of them.
I think that's a really good question. Thank you for that. I'm going to go to the lady behind you, then I'm going to go, I've been on the right, I will come on the left. I'm just...
Hi, it's Eleanor Hayward from The Times. On the Ockenden report, what are you going to do about the systemic failures and the toxic culture that means we keep seeing these repeated maternity scandals across the country? And she was very critical of NHS leadership. Do you support calls to jail managers who refuse to cooperate with reviews? And you know, there's NHS managers, doctors across the country who played a part in these failures who are still working. How can you reassure the public that they're going to be held to account and fired if necessary?
What's your name? I didn't get your name, I'm sorry.
Eleanor Hayward from The Times.
Eleanor, nice to meet you, Eleanor. Thanks for that easy question. I'm sure that'll be. And we'll have one more from over here. Actually, the chap in the blue, if that's all right.
Hi, I'm Eric Salem, Director of Policy at GSK UK. I'm formerly of the Department for Health as well. I wondered, just on the final topic we were talking about, how do you drive the incentives to support the shift towards prevention, earlier diagnosis, earlier treatment, and so on, given that this kind of involves winners and losers in terms of who gets what budgets within the health system?
It's very echoing here. It's like I'm having... What was your name again? Eric. Nice to meet you, Eric. Okay. So, 3 questions there. Health inequalities, the Ockenden report and the toxic culture. And the third one is and then sort of, how do we create the incentives to get prevention moving? Have a go at any of them in any order.
I'll have a go in order, Victor, and please come back if you think of anyone thinks I haven't fully addressed them. There's a lot in all of them. On the inequalities thing, when we first looked at the money last year, first point I would make was there was about £2.5 billion worth of deficit support out in the system. So basically propping up and rewarding deficits, people spending money that wasn't due for them. We tested the allocation formula when we wanted to wean off deficit support and make sure resource was actually distributed according to the formula, so that which would pick up the inequalities thing, where resources genuinely then proportionately devoted to where the evidence says it should be. And that's a constant process. We've made progress over the year there, and it's some big improvements, but more to do. So first point is get the money in the right place. Inequalities, if I'm honest, is one of those things that the NHS have got very good at talking about in recent years. But our commissioners now, our ICBs, should know inside out what their local health needs are, where the inequalities are, where the parts of society are that need to be tackled, in terms of service provision, wrapping services around them, improving access, giving them a better chance. That's what strategic commissioning is about for me. So we're going to be driving that through this year, through commissioning development. And then on the provision side, I do think this is at the heart of the neighbourhoods thing, where we get really organised. And around that footprint, sort of 40, 50,000 population. Depending on where you are, it's not 40, 50,000 people who really need devoted attention. From all the public services. It'll be a much smaller cohort, often hundreds, maximum a couple of thousand people and families. That's what neighbourhood is about for me. Bringing bringing all that to life, using the commissioning framework, assuming everybody's then got a fair share of resource, but bringing to life neighbourhood work, people working together, really targeting the parts of society that need our support. On the Ockenden report, it is a combination of horribly repetitive over recent years. I would say it's similar if you look at terrible child protection reports and failings. You look through them over the years, they say very similar things. And sadly, the maternity reports over recent years have not done. I did that again yesterday. What leaders tell me, and I experienced this as a trust chief exec, is there's been so many views of different reports, different views, what good looks like. It's very complicated and regulatory and oversight environment. We're going to consolidate that in line with the AMOS review into a single set of actions for the NHS, for every part of the NHS, national, local, individual organisations, our colleagues, professional expectations and standards as well, so that we can hold everybody to account on the actions we need to do. We're going to try and do that from the session on Tuesday and then get out really quickly in terms of action to the service. And on the accountability point, everybody needs to be accountable for their actions. We're looking at changes we can make to leaders' contracts. A lot of people often leave and then it's very difficult to account for things that happened on their watch. We're going to try and make some changes to make them, make the system more easy to hold them to account. Where individuals are elsewhere in the service, there are processes ongoing to determine whether that's right and what we need to do about it so that everybody is held to account appropriately. And also just one thing I would say in all this, there's an awful lot in this is about system failures and leadership failures and all sorts of things. There's also some harrowing stories of individual failures where people fail to act with normal, reasonable expectations of compassion and humanity. Those people need to be held to account. So all this, I think, from next week, we'll be pulling together, again, another leadership response to show that we've heard it all. This is a time for action now. We've seen enough of these horrible things. We've got to pull it together and start dealing with it. And then on the final point on the incentives, we're trying a few things around this unbundling of the block contract, I think the flow resource in a different way. Because in reality, if we start shifting patterns of care and people stop being admitted, we have to wait for that to happen to free the resources to start really investing in the things that will stop them coming in the first place and make the wraparound. This is the bit we've usually failed on in the past, or one of the things we've failed on in the past. We haven't got a lot of financial headroom to incentivise that and create double running costs. So we're just trying to get the balance right. And that at the minute is, rather than changing everything nationally, we've changed a lot of the rules nationally. But we're now in an environment where we want to hear what local people want to make local changes to support the flows and incentivisation. And the risk is therefore better managed. And it's more immediate in terms of how that needs to be calibrated. So that's the approach that we're following on that.
Can I just push back, just come back to you a bit on the Ockenden report? Because I think there's a link between what happened there and the question of inequities. So I think you've indicated that it's systemic. And I'm just curious about what do you think is going to be different about this leadership intervention as opposed to other leadership interventions? Because there's been quite a few, haven't there, over the time. Not many of them have worked. I'm speaking as an organisational psychologist. So what's the difference that you think what's going to be different about this one?
So I actually don't think there's been, I'm not being critical of colleagues in previous roles and stuff like that, but I think when we've had reports in the past, there've been those standalone recommendations, but we've not really pulled things together in a unified way, especially given that there are different views still, there are different views and reports and stuff that sometimes suggest one thing's a priority versus another thing. We're going to try and say this is it, there's a single set of actions here.
Okay.
First. It's importantly a whole board responsibility. So we'll be making a point next week. This is nurse directors, medical directors living alongside each other, working alongside each other, with the board to take appropriate action rather than. So one of the problems in maternity is professional tribalism. The midwife's not working as well with the obstetricians and vice versa, or the neonatologists, etc. Trained very differently, they're very independent. Teams often haven't worked well together. So, but fundamentally, I think sometimes we've applied a solution where it's being said to be a system issue, but it might be a professional tribalism issue.
Yeah.
Or we're trying to deal with a tribalism issue. It's actually a personal failure. It's people just not behaving well. They're not demonstrating the required compassion. We're trying to be more discerning in how that works. We will have to tidy up the complexity of the oversight and the regulatory system. Because again, as you described earlier, I was a chief exec for 20 odd years in the service. I would have personally failed a test to describe all of the organisations and bodies that had a view on maternity services. I would still probably fail that test.
Yeah.
Far too many.
Yeah.
So we're going to have to consolidate that again and get into a single version of the truth.
Okay. And just one question before we have to go, I think. I don't have time to go out again for questions, do I? I don't have any time. Okay, just on the question of neighbourhoods and inequalities, that means the NHS is going to have to work more strategically and operationally with local authorities and with the voluntary sector. I have to say, we don't have a great reputation for doing that. We don't have a great reputation. So what's going to shift in the culture of the NHS that means that we will be more collaborative, more partnership focused, more than we have been in the recent past? Yeah,
I think this is a really powerful point, and this is where a lot of this has failed in the past. We aren't. Well, I mean, often, if we're honest, we're not easy to work with between primary and secondary care, or secondary, tertiary care, mental health, physical health, etc. We started the conversation within the leadership community through our oversight framework. We will be working out how we help people build the capacity and capability to work together more appropriately. Encouraging people to work across boundaries. There's a young director coming through. I had a chairman who come from the local government world, and he really drilled into us that our lives was about being alongside the council, being alongside the universities, being alongside the police. Everybody working together in a community, and that's in part true across the service, but often not. So we're going to have to talk about it more, share good practice, be clear in our oversight that it's a normal expectation of the job that you have to do these things. And by the way, that's not about just everybody getting on nicely, it's about how you manage tensions together, how you manage disagreements together, but it's the important one we need to do. So we'll start a programme of trying to encourage people to learn from the best, understand not to books are an island, work with council colleagues, combined authorities, how all the things that you talked about. So I'm confident the will is there. I'm confident there are examples where it works well across the service. Can I just quickly go back to your point on inequity and Auckland and maternity as well?
We're running out of time, but yes.
Yeah, so just very quickly, I think one of the problems in maternity is there are our colleagues. I spent a bit of time with a maternity team a few weeks ago. They were very, very articulate to me that they felt they were managing risk that was different to the risk they would have managed 20 years ago. Older ladies delivering more health complications, more drug and alcohol, different things going on. And our service model hasn't changed appropriately to deal with that. So we're going to have to get better in terms of understanding those drivers in society and frankly, not ignore them, set the service that deals with them rather than just leaving the pressure in the service of people having to juggle with a model that was built 20, 30 years ago when these things weren't as prevalent as they are now. That is a big problem sitting behind some of these issues as well.
Okay, I mean, I hope you're going to talk about the fact that there was a disproportionate number of deaths and difficult experiences from women with various shades of my skin colour.
Absolutely.
Can I thank you, Jim, for your thought-provoking contribution? I really appreciate it. I think we all appreciate the time you've given to us today. Hopefully we'll continue this conversation. We all want to help you. But thank you very, very much for your time. I think you deserve a round of applause. Thank you. I am now going to pass over to Avni Majaria, who's IPPR's Director of Public Services, to introduce our next panel. Avni, it's all yours.
Anywhere here? Yes. Hi. Nice to meet you.
I'm Vita. Hi. Thank you. Is there anywhere? Hello, I'm Munira. Pleased to meet
Nice
you.
to meet you, Munira. Do you want to take the seat?
Yeah, I was just going to grab a glass.
Of course, yes. Thank you for doing this. It's very hot. Yes.
Oh, sorry. Sorry. I'll get out your way now.
Oh, no, good.
Shall I pour you water?
Oh, that would be lovely. Thank you so much.
Help yourself. Hi, Andrea. Nice to meet you.
Hi, nice to see you. Hi. I'm Natasha. Natasha, hi.
Thank you very much.
Would you like some
I've
water?
got some
I've
down
got
here.
some. Oh, sorry. I didn't realise that was for me.
Hello, everyone. Thank you for making it on such a warm day and making it in person. Really pleased to see you here. This session is going to focus in on the health of children and young people, brighter beginnings, and whether the government's rhetoric has whether the reality of what government has done has matched the rhetoric of building the healthiest generation of children and young people ever. When we look at the case, we can see that there's been billions of pounds of investment, moves towards setting out a 10-year health plan, but outcomes for children and young people are either stagnating or some are getting worse. And so this panel session will examine what needs to happen to change that and how we can implement that. We've got around a 45-minute panel for you. We'll have some opening remarks from the panelists. Following that, some debate amongst the panelists, and then there will be an opportunity for questions later on in the panel. We should be all wrapped up by 12:50, and there'll be lunch following this next door. So without further ado, our knowledgeable set of panelists here. Let me introduce them before handing over. We've got Munira Wilson, the Liberal Democrat spokesperson for Education, Children and Families. We have the Right Honourable Dame Andrea Leadsom, founder of 1001 Critical Days, most recently, but following an extensive career following an extensive political career, background as a government advisor. And then we have Baroness Nargand, a leading expert in reproductive medicine and women's health, and a Labour peer, and Natasha Fine, head of policy and influencing our impact on urban health. Thank you very much for being here, panel. I'll hand straight over to Munira, if that's okay, for your 5 minutes of opening remarks on this topic.
Brilliant. Do you want me to stay here or do you want me to go to the lectern? How are we running this?
You're fine there, your mic's up.
Great. Well, thank you. I hope you're not all wilting. So as you heard, I'm Munira Wilson. I'm the Liberal Democrat spokesperson for children, families and education. And I repeat that deliberately because in the title that Ed Davey gave me when he appointed me to this role, we were trying to reflect a holistic approach to children's lives, because children don't fit neatly into a single policy box or a single portfolio or department, and they're nearly a quarter of our population, and ultimately their well-being is shaped by every department across government, from education to health to housing to welfare to culture, media and sport. And that's why whenever I'm in any discussions and debates, and every room I enter, I try to bring, where I can, children's voices and the challenges they are facing that I hear about from them. And that's why I'm really pleased to be here. So thank you to IPPR for inviting me, because I know that you have been leading the way with some of your recent reports on a really bold vision for children's health and well-being, which is a cause that I and my party passionately champion. But I do think children have been let down a lot by successive governments, and whilst there have been some really welcome policy changes from the current government in support of children, I don't think many of them are underfunded and perhaps not very well joined up. And to take health specifically, whilst they make up 24% of the population, children receive just 11% of NHS spending, leaving the UK in the bottom third of high-income nations for children's mental health in particular. And I think the relentless and very important focus on elective care backlogs means that children, and especially children's mental health, are often an afterthought. Now, I think a fundamental driver of this failure is a vacuum of political accountability and short-term thinking. And there's a really good recent example of this. We saw a real bureaucratic tussle between the Department for Education and the Department for Health and Social Care recently over PE and sports budgets. And some of you may have seen some of the media coverage around that. And whilst there has been an announcement in recent weeks, there is ultimately still going to be something like a 22% cut to those budgets going forward. And so I think there you see the government actively undermining its own very positive and laudable ambitions, and it's children who will pay the price in terms of their physical and mental health. We as a party, the Liberal Democrats, believe in fixing that accountability gap. We've long called for a cabinet-level minister for children and young people, because I think I realise that's part of Bridget's portfolio with education, but I do think somebody looking specifically cross-departmentally at children and young people is really, really important. And I think IPPR's research certainly echoes that structural urgency. And I know that the IPPR has called for the strengthening of the Children's Commissioner role and establishing a data-driven children's unit, because children are touched, as I've said already, by every single department, and so they need a unified data-backed champion at the heart of government. And when it comes to schools, which obviously I focus on a lot in my portfolio because I'm not health, the thing that I hear time and time again from teachers and head teachers is that they see themselves as the fourth emergency service, not just focused on teaching and learning, but picking up a lot of those services that are letting down children outside of school. And so I think there is a unique moment. We've got falling pupil rolls, especially here in London, but elsewhere across the country. And I don't think that the Treasury should see that as a moment to bank that as savings, because we've got per pupil funding in this country. And I think that the Treasury shouldn't be clawing that back, and that money should be freed up and reinvested into our schools, particularly in investing in those enriching activities and subjects, including physical education and sports, that's so beneficial to a child's mental and physical health. But if we take a whole system approach, that's also got to start with early years, and the current childcare expansion has helped lots of families, let's make no mistake, but I think we've become quite short-sighted about its true purpose. And right now, the state, I think, treats childcare as a narrow, short-term economic tool to boost parental working hours. But if we were building an early years system from scratch, is that really what we'd want it to look like? Because I don't think it's meeting either parents' or providers' needs at the moment. And many of you will have seen in Alan Milburn's recent report. He said, from the moment a child arrives at school, the system knows who is most likely to fail. I think that's completely unacceptable, and therefore we've got to, and I'm sure Andrew will talk about this in depth, we've really got to focus on that on those early years. Look, as a Liberal, I believe every child is born with a promise, with something innate in them that we have, that families and the state has a responsibility to provide the support and the opportunities to draw out. And we need a system that focuses on and prioritises a child's well-being, their development and health equity, empowering families with the choice and the flexibility they need to thrive. And so what I think we need is a parental leave and an early years system that prioritises children's development, delivers meaningful flexibility for families, and puts children on a secure path in those early years. If we're truly serious about building a healthier, fairer society, we have to stop treating our children as an economic afterthought and a cost line in every budget, and start investing in them as the very foundation of our nation's future. Thank you.
Thank you very much. We'll just move down and take your opening remarks. So, Dame Andrea.
Thank you. Babies. So who here remembers when they were a baby? No one. None of us, do we? We don't remember it. But actually our subconscious does. So all of us, unless we're taught otherwise, will parent exactly the same way we were parented. We all remember it when our instincts kick in when we become parents. And why is that? It's because human beings are unique in the animal kingdom in the extent of our underdevelopment at birth. So think of a cat, think of an elephant, think of them being born. They stand up, they walk off, go and play, go and find some food, go and do something. What did all of us do when we were born? We lay there, didn't we? We did nothing for ourselves until we were at least a year old, more like 2 years old. And the physical underdevelopment of the human being is only a tiny part of it. By the way, if you're interested, it's because when we came down from the trees and we'd already won the evolutionary race, evolution had to decide, okay, well, women's hips need to get narrower so they can walk on 2 legs. So either they need to have babies with smaller brains, smaller heads, smaller brains, or they need to have babies that are more premature. So clever old evolution chose more premature. That's why we are born about 2 years premature. So the physical underdevelopment, those cute little arms, those gorgeous limpid eyes, that's just a part of it. Babies are programmed to survive. They don't know that you're mum, that you're dad, that this is granny, that this is a house. They don't know any of that. They just have the amygdala, the flight or fight part of the brain, the instinct to survive. And so what they do is they use their cute eyes, they use their piercing cry to make sure that the loving adults around them cannot possibly ignore them. And the reason for that is because they cannot do anything for themselves. So they engage with the adult, and the adult fixes everything until that baby is old enough and developed enough to fix itself. Okay, so this is absolutely proven science, 50 years worth. Don't believe me, go and look it up. The fact is that a baby's brain puts on 1 billion neural connections in a minute of its first year of life. 1 billion connections a minute in those neural connections. And those neural connections are being made relevant to the experiences that that baby has. So when a baby's wet or tired or hungry, he or she doesn't know he's wet or tired or hungry. He just knows something's wrong, stress, cortisol, cortisol, wah! And you cannot ignore a baby crying, can you? No, nobody can. Even if it's on the bus and that has nothing to do with you, that baby just shut up. And that is, babies are programmed to make sure nobody can ignore them. And the loving adult carer, the attuned loving adult carer, will go and rock you and change you and feed you and wind you and sing to you and please shut up. And in the end, your cortisol level comes back down. And over time, in fact, within 6 months, a baby learns to soothe itself. And that's when the amazing bit, the prefrontal cortex, which is that cauliflower part of the brain, starts to put on its peak period of development, 6 months to 18 months. That's when we learn to self-regulate. It's what differentiates us from animals. We can self-regulate because we can empathize, we can feel another's pain. We can feel sympathy. We can feel pleased for you that you've done so well at school, that you've got a lovely watch, which I wish I had. We can feel pleased for each other. We can feel sad for each other because you've been ill, because you've just lost your parent or whatever. That is the human thing, and it's not there when you're born. It develops between 6 months and 18 months. And the reason for telling you all this is because it is so crucial to why children are not school ready, to why children have so many mental health problems, to why there is so much neglect and abuse, to why your greatest risk of dying a violent death is when you are less than 1 year old. At any age of life, you're more likely to die a violent death when you are less than a year old. Why? Because you are so vulnerable, because you are totally exposed to your loving adult carers. And of course, if they're not loving adult carers, if in fact their experience as a baby was to be screamed at and punched and shaken and told, shut up, or ignored, totally ignored, then that parent will not have the instinct to nurture you and love you and deal with your needs. And so it's a cycle of deprivation. It goes on through generations. And it's absolutely right what everybody says. Things are going worse. We're spending more and more on children's school readiness, and children are less and less school ready. And what do policymakers do? They don't look back at why they're not school ready. They try and fix the school readiness. I was talking to UNICEF the other day, telling me about how they're focusing on the second 1,001 critical days. And I'm like, what's that? Well, that's 3 and 4. And I'm like, no, those aren't the critical days. Those are the trying to firefight because you didn't get the 1,001 critical days right. Pregnancy to age 2 is what it's all about. Now, everybody knows that women's bodies change massively when they're pregnant. Who here knows, hands up honestly, if you know that a man's body loses 25%, a quarter of his male testosterone when his partner's expecting a baby? Come on, all those hands going up, you all knew that, didn't you? Okay, so there's a few of you did know that, well done. Most people, I go around the world saying this and literally everyone's like, really? Didn't know that. And so what does that do? It makes men feel weird. It makes them feel physically weak, makes them feel a bit tearful. That's not good if you're a macho young man who's just about to become a dad. And actually, we also know that 30% of domestic violence begins in pregnancy. And it's because men feel left out, because midwives don't talk to them. If he's lucky, mum will be asked, so how's dad? And mum's saying, well, he's over there. His name is actually Fred. Why don't you ask him? But no, midwives ignore dads. And then, of course, when dads, I met this lovely guy who'd had his legs blown off in Afghanistan. He was looking after his wife and baby. He was driving her to all her antenatal checks. And he was left outside because you're not allowed in because you're a man. And so when the baby was born, wife was in intensive care and he was presented with the baby and told, right, get on with it. And he was like, well, it would have really helped if you'd let me in on any of the antenatal classes, if I'd had any information whatsoever. I now have a wife in intensive care and a baby, no legs, and I've no idea what I'm doing. Great, well done, NHS. So all of these things, what we actually need to do is to focus on pregnancy to age 2. And in all my years as government's early years advisor, and now I've founded a charity called the 1001 Critical Days Foundation. Its mission is to persuade the entire world to legislate in primary legislation to support pregnancy to age 2. Because if we get that bit right, the rest of it follows as night follows day. You know, your brain is most plastic when you're under 2. It's very plastic when you're in puberty, and it's also very plastic when you're about to become a parent, as mum and as dad. And the thing that parents and carers, young, old, rich, poor, educated, ill-educated, the thing they all said to me when I asked them, what is it you need to help you be confident as a parent? Information. Information. Where's the off button? Sorry, there isn't one. Why does my baby keep crying? Why won't he sleep? Why do I feel so awful? What should I be feeding him? When should I wean him? All of these things. Parents desperately need information, and a lot of parents need support. So 50% of UK children are securely attached by the age of 5. 35% are insecurely attached. Not a disaster, but it means they'll struggle with life's ups and downs. And 15% have disorganized attachment. Those 15%, there is a wealth of global evidence that shows those 15% will cost 80% of all the costs in society, of ill health, criminality, drug addiction, suicides. All of the awful things are reserved for those who had the worst beginning when they were less than 2 years old. So that's how we can improve the plight of children and adults, is by focusing on pregnancy to age 2. Thank you.
Thank you very much. Over to our next panellist, Natasha from Urban Health.
Thank you. So I work at an organisation called Impact on Urban Health, which is a health foundation and funder based across the river in Lambeth and Southwark. We work to make city environments as healthy as they can be, so all the way from things like cleaner constructions to healthier high streets. And one of our kind of key areas of interest is really thinking about how we can make towns and cities as friendly for children as possible. So really excited to be here. I think kind of based on the comments so far and the conversation in the room already, we're all here because we believe that children deserve to have the best chance in life to be happy and healthy, to feel safe, to thrive. I do think that argument has been won, but I think there is still far too big a gap between the things that we know need to happen and the lived experiences of children's lives. So the street where a child grows up on still determines their long-term health. In one part of London where we're based in Lambeth and Southwark, a child might wake up in a mouldy home with parents struggling to make ends meet. They might walk to school down a polluted road and have limited access to healthy and affordable food. Just streets away, another child might be living in completely different conditions. And these differences, as we've already heard, compound over time and affect a child's health, both in the immediate term, but also long into their future. It doesn't have to be this way. The conditions that shape children's health and result in these vastly different and avoidable outcomes are the result of systems. They're the result of decisions. We can continue to make those decisions, or we could choose something different. Last year, we were very happy to work with IPPR on a piece of work that really looked at the importance of children's health for national prosperity. As we enter into this brave new world of what comes next for the government, I'd like to reiterate one of the key recommendations from that report, which I know others in the room, including the Royal College of Paediatrics and Child Health, also advocate for, which is the Children's Investment Standard. So the purpose of that really is to safeguard spending on children's health and to really kind of hardwire that preventative approach to spending, both in the NHS but also in broader public services, because we know so much of what determines a child's health, as we've already heard, is those kind of wider conditions in which they live. There is so much goodwill in our public services to do right by children, to give them the best start in life, but the kind of very patchy nature of funding, the short-term nature of funding, means that there are some areas and some services that are really being left threadbare, and that results then in these vastly different outcomes. In the past couple of years, there have been some really promising policy changes, those kind of green shoots that Victor alluded to earlier, things that will support children's health in the long term, including the scrapping of the 2-child limit to kind of address child poverty, also the expansion of access to free school meals to ensure that children have more access to healthy food, which they'll need to learn and grow. But there is so much more to do. The neighbourhood health agenda that I think we are going to get on to speaking about later, I think does have real potential to improve children's health and particularly to address some of these really deep-rooted inequalities that we see. So I'll end there.
Thank you very much. And finally, Baroness Nugent.
Thank you. Thank you very much, IPPR, for inviting me to this very important conference. Let me start with a simple truth. We need to create healthy lives and achieve healthy outcomes, not just longer ones. And my fundamental message is basically, unless we address wider determinants of health, we are not going to fix this. NHS alone cannot fix for everyone to have brighter beginnings and to build healthy futures. Health is not just in the hands of NHS alone. We are living longer on average, but there's a 20-year gap in healthy life expectancy between the child born in the most deprived communities and the child in the least deprived, and 20 extra years of living in poor health for those in the most deprived. This is unacceptable in one of the wealthiest nations of the world. Just as simple as that. And the only way we can address is by addressing wider determinants of health. And I want to concentrate a little bit more. I'm an obstetrician gynecologist, so in a way about preconception and intra-uterine environment as well. When families have sufficient resources, children are healthier. When families are poor, children are sicker. So there is a direct link that wealth determines health. A child born into poverty is more likely to be underweight at birth, to miss key developmental milestones, and to grow up in damp, insecure housing. That is why the social determinants of health matter, and that they must sit at the center of the conversation for brighter beginnings and building healthy futures. Housing shows this starkly. Energy bills have risen, we know that. More children than ever are growing up cold and damp. Between April 2019 and December 2024, 104 children have died with temporary accommodation as a contributing factor, and 76 of those were under the age of 1. Income and health have a causal relationship, and it's nowhere clearer than in the walls a child grows up. The bodies and brains of child developing in poor families will have long-term health consequences. Health is determined before birth. In fact, it's determined preconception. We know that. We know there are so many elements preconception can determine what goes on later on. But if those of you who know about David Barker from Southampton, who did a huge amount of work as regards to the future health of children. So the Barker hypothesis that he published showed us that intrauterine environment shapes the lifelong outcomes. Poor maternal nutrition and stress, often consequences of poverty, increase the risk of ill health later. So today's child poverty is tomorrow's adult illness and tomorrow's health inequality. So we know intrauterine environment leads to increased risk of cardiovascular disease, metabolic diseases later in life. But can I also say, when we are discussing maternity care or women's health, maternity care is not just women's issue. Women give birth to little boys, and their future health is determined, and their risks of long-term conditions, metabolic conditions, is decided inside the uterus, and some of it even preconception. So maternity care has got to be taken as care for everyone, not just women's health care. And the report that was published just day before yesterday on fetal alcohol spectrum disorder, which is one of the most under-recognized neurodevelopmental disorder. And you know what? Roughly one child in a classroom of 25 has got it, and it's costing the UK economy 9.2 billion a year because it's not being recognized. So really, I think if we're looking at changing the beginnings and building healthy futures, because I always say this, WHO might not have got everything right, but it certainly did get the definition of health right. It is not merely absence of disease. It is about physical, mental, social, and emotional well-being of the person. So if that is what we want to achieve, we have got to address social determinants of health, because we also know about death rates in different areas. So early intervention, prenatal and preconception interventions are necessary. This is the political story we have got to talk about. Children's health cannot lie at the door of the BHSC. It's got to be cross-governmental. It's got to be cross-sector. It is about working with local governments, voluntary sector, and because neighborhood is a community. Neighborhood is not a clinic. It is about your local pharmacy. It's about your local high street. It's about what happens. So if we're talking about neighborhood health hubs, then we have got to talk really about addressing social determinants of health. And so we need a complete shift of paradigm about how we work for healthcare. It's not managing sickness. It is about creating health, creating healthy children. So just to say, if we want to do this, change this for everyone in our country, when we have such huge child poverty, and we know that affects future health, then we have got to address prevention, and the prevention starts before pregnancy. And I heard Victor, when I came in, saying about black women dying more than twice as regards to maternal mortality than white women. So all these matter if we're talking about the future of children. So I think, in my view, if we want to address this, and thank you IPPR for this, addressing brighter beginnings and building healthy futures, let us address wider determinants of health. Let's get everyone to work together so that we create a brighter future and healthy lives for the future. Thank you.
Thank you very much. So we've got a little bit of time for debate amongst us. We've talked extensively about the social determinants of health, the impact on the now and the future. Let's take a look at the government's plans and whether they have the potential to address some of the points that you've made. Thinking carefully about the government's 10-year health plan, what needs to happen within the prevention and the community space to address some of the elements that we've talked about? And that's a kind of beginning question, but this is some time for debate amongst us, so please feel free to pose your points and questions to other members of the panel also.
Well, just hot off the press, there is a private member's bill called the Babies Bill that's being brought forward with significant cross-party support, which the foundation I've set up is supporting also. And that Babies Bill intends to enshrine in primary legislation exactly what the family hubs, the Best Start Family Hubs and Healthy Babies programme is already doing. So for me, as the previous minister, so Sharon Hodgson's the Minister for Start for Life, I held that job previously in the last government, and before that was the Early Years Healthy Advisor. And so what it seems to me that what parents want is information. They don't want to be stigmatised, and they want to find all the services they need in one place. And I agree with everything that's been said about the importance of early support. The earlier you get in, the better. And parents are crying out. It's not, there used to be this debate, oh, is that a bit nanny state to be telling parents what to do? No, no, no. Parents are desperate for advice and support. So what this Babies Bill, which just before coming here was talking with civil servants about how the government can support it, is all about delivering good antenatal care, good health visiting care, good parent-infant relationship support, good infant feeding support, good mental health support for parents, carers and their babies in the period from pregnancy to the age of 2. And these things are really integral because, we all know poverty is a huge correlation with bad outcomes for babies. But actually, an even bigger correlation is parents who themselves were appallingly parented. So it's a cycle of deprivation. So actually, to turn it around, whether you're rich or poor does have a big impact. But if you're unsupported as a parent, that has an even bigger impact. And so actually, the one thing we can get right, because we actually already have it, that programme has been up and running, it's in its 5th year now, and the government is supporting it. And I've no doubt, if Andy Burnham becomes Prime Minister, that he will continue to support it. And that, in my view, far more important than the 10-year NHS bill, is this specific focus on where it all begins.
Thank you. Munira, can I bring you in?
Look, I'd support all of that because we know all the data says it is about those 1,001 days and indeed early years. And I would like to see a real focus on prevention beyond the 1,001 days. We have seen in recent years cuts to public health budgets, and we see vaccination rates are not where they need to be, obesity levels rising, lots and lots more children who are suffering with their mental health. Now, the Conservative government introduced something called mental health support teams, which is a shared thing between schools and the NHS. This government is committed to rolling that out to everywhere, but the reality is they are stretched across multiple schools, and then they're often not joined up back with the GP, and those who need escalation and so on aren't getting the support they need. So I think it comes back to what I was saying before, that really cross-portfolio, cross-government focus on children's health, starting with prevention and early intervention when problems are occurring. And look, I've never been a fan of targets because it often drives the wrong behaviours, but we know that in mental health, a number of the targets have been scrapped, and I think there isn't much around children specifically, and I do think sometimes it does help focus minds, and alongside that, data collection. So again, for children's health, data is really, really fragmented. And when we look particularly at mental health, the Children's Commissioner, for example, every year uses her powers to request all sorts of data from different parts of government to put together a full report of what it looks like. I did try and bring forward a private member's bill in the last Parliament. Unfortunately, it wasn't supported by that government to have that annual reporting mechanism. So again, for me, it's prevention, early intervention, but also trying to deal with that fragmentation and almost having like a children's plan that is cross-government that brings all of these different elements together, because at the moment it's just not working for children and they're just being forgotten about.
Yeah, well, everything has been said already, but I really, the 10-year plan and what's in there as regards to shifting from treatment to prevention and also going into communities and neighborhoods. I mean, I like the way they have already said that, as well as analog to digital. So ingredients are there as regards to NHS side of it. So, but we need to know how much is going to be for prevention, what amount is going to be allocated for prevention. How do you do that? Because that is where this collaboration has to come with cross-departmental and cross-sector, and with local governments and voluntary sector. And also the single patient record will give that benefit digitally to trace absolutely everything that's happening from first day of pregnancy, when the actual pregnancy diagnosis is made, until what's happening in childhood and for young people. So I think, the NEAT report has showed already that it's not actually a job crisis, it's a health crisis with a job problem, and with the mental health problems, loneliness that's going on. So we need to shift to that as well, because we need to bridge the gap between education and employment for young people, and the voluntary sector can play a huge role in that. So to me, I think ingredients are there in that 10-year plan. Let's make sure that we implement them with collaboration and measure the outcomes and monitor them, and because we're going to have the single patient record as well. So I think the opportunities are there for us.
It's hard to go last when everyone says loads of good stuff already. So I guess, to start with a positive on the 10-year plan, I do think the fact that there is an ambition around children's health is really positive. And that commitment helps health services and the wider system understand that this is something they should be focusing on, and ideally helps us all point in the right direction. There are lots of challenges, as Munira set out, in terms of the fact that children's health is so fragmented leads to issues with accountability, just like a very short-termist approach to policy making, political change and instability. So there's all of that, and I think actually just to pick up on something you said, Munira, around targets, which I completely agree with, and I think targets can be really helpful for focusing the mind, but I think sometimes there can be a danger actually of focusing too much on achieving the targets and not enough on delivery, and I think there are some circumstances actually where targets can unintentionally create a perverse incentive that might actually widen the gap rather than close it. And just as one example, we've been doing some work with the Institute for Government recently, which I hope is okay to say on an IPPR panel, which is essentially looking at the government's opportunity mission That recent report, which is out last week, essentially warned that the government's early years target, which is around 75% of children reaching a good level of development, like really good in principle, I think we can all kind of agree with that. But the way that target is kind of has been put together essentially doesn't do enough to incentivize the system to focus on children from low-income families who might be kind of furthest away. There's a potential for systems that are under pressure to focus on the children who are kind of closest to reaching that good level of development. So I think, something around ensuring that there is a very clear sense of like vision and mission, but not getting too caught up with the targets.
I'm going to take some input from the audience. I'll take 2 sets of questions in threes, and then we'll pose them to our panelists. Starting at the back on the right, please.
Sign up. Hi, everybody. My name's Aditya Agarwal. I work at the Institute of Global Health and Innovation as a researcher, and I'm also a qualified pharmacist by background. So one of the questions I have is about supply. So we had early this year, we had a situation where we couldn't supply formula milk, and then there was huge price hikes, and that impacted individuals' health because we were unable to supply basically medicine for babies, basically, and that caused huge price hikes, and we were pretty powerless to do anything, and in some cases we just couldn't make the supply. That then put the babies in hospital because there was that nutritional gap. What role do you think government has in supporting in that? Because that is also affects individuals at a local level. But I found a particular disparity in the areas I work. So I work in the home counties. In some areas, people were able to afford to pay that price hike, and whereas in others, they just simply couldn't. And that you could see that having a detrimental impact across different systems.
Over here, and then we'll go right to the back on the left.
Hi, my name's Dr. Zach Hassan. I'm a frontline doctor and here with the Healthcare Leadership Academy. My question is about policy barriers. So the panel together have made a very convincing case that something should be done about this and it would be beneficial. We've known since the Beveridge report, the Black report, Marmo, that investing in early years is really important. But the political context at the moment is that the government doesn't really want to spend money on these people. In fact, the last government brought in the 2-child benefit cap, which undoubtedly is going to worsen this. So my question is, how do you actually make this happen, especially overcoming the Treasury veto power? When Andy Burnham comes in, if he does, he's going to experience a lot of pressure to raise the welfare budget to pay for defence. So what is the answer to that? How do you actually make this happen?
Thank you. And one more at the back on the left.
Thank you. I'm Vicky Nash from Muscular Dystrophy UK. I'm really interested in the panel's views on the role of newborn screening when we're looking at kind of the importance of babies' lives. Munira, I know you were at the newborn screening debate on Monday. We're in a 10-year battle to get a very rare condition, spinal muscular atrophy, onto the newborn screening list. It is literally a life or death matter. And the response that we've been getting is actually our newborn screening approach in the UK is best in the world and the most robust in terms of assessing international evidence. 75% of European countries have it. Ukraine has rolled it out during a war. Or is it actually that we're just ever so slow at these things?
Thank you. Okay, so we've got 3 questions there. One on the role of the price of medicine supply, the role of government within that, and the potential to deepen inequality. One on policy and political barriers to getting the things that we all agree need to be done. And finally, one on the role of newborn screening. Would you like to come in?
Happy to kick off. I'm sorry, because of the acoustics, I didn't catch everyone's names, but on the short-term funding versus long-term. investment. I mean, this is a perennial problem, right? Every politician and every leader, political leader, thinks in electoral cycles. And the problem is for the early years and children's agenda in general, the return on investment, oftentimes, some of it will be within a short space of time, but often you see the best returns on investment 20 years hence. And trying to convince the Treasury of investing is really, really difficult. I mean, I think there's a case for governments to challenge those Treasury rules and how we look at children, spending on children's services and education, so that we can classify some parts of it as an investment, as we do spend on capital infrastructure, so that where you're borrowing to invest in infrastructure, you could be borrowing to invest in some elements of education and children's services. I don't know what that would look like in detail, but I think it is a concept we should look at. And to be fair, I know from discussions with Justine Greening, who's a previous Conservative Education Secretary, once she stepped down from government, I think this is something she was trying to explore, because she'd worked both in the Treasury and in the DFE, and she'd seen how those tensions were playing out, and you couldn't make those long-term investment decisions. But every government's plagued by the same thing. With the best will in the world, Andy Burnham's staring down the barrel of a general election in 2 or 3 years, possibly sooner if he gets a poll bounce. He ain't going to be thinking about what can I do now that's going to help children who are adults in 20 years' time to become economically active and fulfilled citizens, personally. And that's not a political comment. I think we all suffer the same affliction in every political party. It's really, really difficult. So it's not an easy conundrum, but we will keep banging the drum. Just on the screening point, as you say, I was in the debate the other day. Look, all the points you make were raised about the fact that the UK is an outlier in terms of our screening programme. It was very interesting when Sharon Hodgson was responding as the minister. She was very, very sympathetic to a lot of the arguments and was quite clearly struggling to hold up the government's line as to why SMA, and I would say indeed there are other very rare conditions that aren't included in the newborn screening programme. Ultimately, we know it does again come down to cost, and whilst it may, the additional cost of adding in an extra test on the newborn screening might not be huge, the knock-on impacts of that will be immediately quite big. So for SMA, it means that you might get gene therapy, which we know is very expensive. But ultimately, again, the long-term savings in terms of social care, for instance, so that a child isn't left in a wheelchair or needing breathing support or whatever it might be, are huge. But ultimately, it comes down to nice and rationing of healthcare resources. But it is like every party that was represented in that room was saying the same thing. This is a no-brainer. There's international evidence to back this up. You shouldn't be still trying to run trials. I mean, the trial they're going to run is basically going to mean 68% of England's going to be covered with this screening for SMA type 1, but the other 22% won't be. I mean, it's bonkers. It's unethical, as clinicians have said. But again, ultimately, it comes down to investment.
Yeah, thank you very much. The first one was about medicines price and supply, I think. I mean, to me, like, the NHS has this huge single purchasing power. Okay, so using that single purchasing power, we should be able to achieve reducing price and increasing supply. And that is the power that so many other countries don't have as much as we have. In addition to that, what I would say here is the trade agreements that are happening with countries where these medicines are made, and one of the examples is India, is where those trade agreements need to be expedited to ensure that the medicines price and supply are as we want it for our country. And of course, as part of that, I would say we should be encouraging more science and innovation and entrepreneurship in our own country so that we will produce them ourselves and reduce cost. As regards to bits about two-child policy gap, that's been addressed, and Best Start family hubs are there. There is a strategy for addressing child poverty, and I have no doubt that the government has taken it seriously and will be addressing that. When it comes to newborn screening, completely agree with what Munira said, totally. My only 2 points I want to make is we must make sure, of course, we produce the evidence base, we update NICE guidelines more frequently so that they are not 10-year-old, and with the latest evidence, and we address that. We should also address the uptake in BAME communities and all that, because then we want to make sure they're not left behind. So we need those public health campaigns to make sure when we have this evidence-based screening that everyone gets it and everyone takes it, and we need that campaign.
Natasha?
Yeah. So I won't repeat comments that have already been made, but on the first point around rising costs of like access to formula milk and medicines, I think that speaks to a wider point about inequality and poverty, and I don't think it's been named yet on this panel, systemic racism, which means that it is much harder for some families to afford the basics. Doesn't speak directly to your point around formula milk, but I think this is such a staggering statistic, I wanted to share it. We work with an organisation called the Food Foundation that in a recent report found that the poorest households would need to spend 85% of their disposable income in order to meet the government's recommended healthy diet. So I think there are these staggering inequalities that exist. We need to be taking them really seriously and really ensuring that any policy making we do is really explicit in narrowing those gaps.
I'll just address the formula point, because nobody's mentioned it, that actually breastfeeding is free, very easy. If a baby gets a bug, within 20 minutes, mother's breast milk has produced the antibodies that the baby needs to make the baby be healthier. Breastfed babies are 10 times less likely to become obese, suffer heart disease or diabetes in later life. So I think actually what is very clear is that so many mums would like to breastfeed and don't feel they have the support, and therefore support for breastfeeding is a very good, very cheap way of reducing the reliance on formula milk companies. And frankly, as a minister, I was always an advocate of stockpiling, which is what the rest of Europe does with essential things, but for some reason we don't do it, which we absolutely could do, and that would then solve short-term shortages. And then I think the other thing I would just say is that when it comes to the support for breastfeeding mums, that goes to the whole of society, because actually there's far too much cultural, this is disgusting, and actually the UK now is one of the lowest breastfeeding rates in the world, and that doesn't have to be like that. The SMA milk companies in South Africa give women free formula milk when they are in the first couple of weeks of their baby's life, so that their milk doesn't come through. And then what happens is babies get fed very, very watered down formula milk with dirty water because mother's milk didn't come through. And the formula companies say don't breastfeed your baby because HIV is endemic, blah, blah, blah. So I actually think there's a big question over the behaviour of formula milk companies. I feel I can say that now I'm no longer a politician.
Thank you. Did you want to say anything on the political barriers to improvement, the question from the gentleman over there?
Well, the reality is, as I think I've set out wholeheartedly, when I was in government, we created this thing called the Family Hub and Start for Life programme. The new government has carried on with it under the Best Start Family Hub and Healthy Babies programme. It's well funded. The trouble is local authorities do what they feel they like to do rather than necessarily what they've been specifically paid to do by government. So actually, as so many things with implementation, it's the implementation that's the problem, not the funding for it. So actually the money is there, and actually I personally have a lot of time for Andy Burnham. He kept the Sure Starts going in Greater Manchester, and Lucy Powell, who is Manchester Central MP, Labour MP, the two of them and I have always been massive allies on early years, in fact, as has Munira. So this is a really cross-party agenda. If we just do what we've got the budget to do, but actually make it happen, and that requires a bit of effort on the part of civil servants and local authorities, then I think we'd actually be in a much, much stronger position with support for early years.
Right, I'm just going to take 2 more questions from the audience and then ask for super punchy answers from the panel. There was somebody over here that I missed in the first round. Yes, gentleman at the front, and then we'll take the lady on the left.
Hi, good afternoon. It's Dave Munday here from Unite the Union. In the last 5 years, the number of health visitors in England has been cut by 21%. If panel members had or have any power to impact on this statistic, what would they do?
And just one more here.
Hi, Chloe Rollings from Carers Trust. My question is, what could and should be done by government to support parents and siblings of children who are born with a disability or health condition who are trying to navigate that parent carer or young carer role, particularly in those early years?
Thank you very much. So we've got a question about health visitors and the reduction in health visitors and the what should be done by government to help parents that are born with children with disabilities. Yes, go for it.
Look, if I had a magic wand and all the money in the world, obviously I'd reverse those cuts. Health visitors are critically important. I remember as a new mum how valuable I found those visits, and they're really often important in picking up early problems in terms of illness. Andrea's talked about breastfeeding for those mums who are trying to breastfeed and maybe struggling with it. They can help, but also signpost them to other help. So, yeah, I mean, health visitors are undoubtedly critically important, and a lot of those, I think, went online during COVID, and I know it's been patchy in terms of health visitors returning fully in terms of face-to-face since then. In terms of carers, and particularly young carers, I mean, this is an issue that's very dear to my party leader. As you know, he's got a disabled son, Ed Davey, and we've always championed carers, unpaid carers, particularly young carers. And I think, I'm just going to pick up on the young carers point because we've been asked to keep short. I think schools need to do a lot more in terms of tracking. I know that there is now some census and data collection on young carers, but still I hear too often when I talk to young carers locally that actually their schools don't quite know how to support them, help them understand their needs. And same goes for those children growing up in kinship care, and I've done quite a lot of work around kinship carers. It's very, very similar themes. So I think, again, it's not just in health, it's in education, it's across all the different services, knowing what signs to look out for and where to signpost people to and provide the right help and support.
Thank you. Anybody particularly want to come in next?
Yeah, happy to. On the health visitor situation, my understanding actually is that it's less of a cut and more of a health visitors leaving the sector and new health visitors not coming into the sector. So in my very long time in government, it was always about trying to make health visiting a more attractive role, doing a lot of work with the Institute of Health Visitors, and certainly a lot of health visitors feel that there's not the onward support. So if they identify something, or what do I do about that fact that this person is clearly psychotic or just depressed, or there's domestic violence or whatever. So, I mean, without wishing to sort of have a one-size-fits-all, the idea of the family hubs having health visiting within their walls means that you're in one place as a health visitor, meeting families, and this person here is the breastfeeding support advisor. This person here is the family navigator who will make a cup of tea and provide a bit of, arm around a new parent, etc. So I actually think there's a lot to be done around ensuring health visitors feel motivated and empowered, but also much more different levels, because health visitor is a very prescriptive role. It's got a NHS grade, it's got a band, you have to be a nurse and then you've got to train for 2 years. There was an attempt to bring in a health visitor apprenticeship, and as far as I'm aware, nobody's ever taken it up and it's not really been marketed. So I think that actually health visiting requires much more of a holistic review, and I think most of the problems are people voting with their feet and getting out of it as opposed to budgets being cut. But you may have a different view. In terms of the disability, again, family hubs are required to support people with children with disabilities. Now, obviously, it depends on the disability very much, but certainly I visited about 80 or 90 family hubs, met with lots of parents with babies with disabilities, ranging from delayed learning to cerebral palsy to, impaired vision, etc. And what parents have always said is we don't want to be down there for parents of blind babies and babies with disabilities. We want to be with other parents. We don't want to be segregated and treated as different in some way. So again, this whole argument about a one-stop shop for families, regardless of the needs of your baby, proportionate universalism to support those where there are disabilities, in my view, is absolutely crucial, and that's what parents want.
Well, I agree with what's been said, but as regards to health visitors, I didn't know about that statistics, but I think we may have to redesign their job descriptions and a little bit looking at exactly what they are doing and based on the need. I agree that with Best Start Family Hubs, there is an opportunity to address that so that there is a holistic approach rather than that. So yes, we do need to train more people. We do need to make it attractive, no two ways about that, so that there is actually some sort of a progressive role for them going forward as regards to their career, because otherwise they are not interested in that. So apart from addressing the training and making it attractive, but we also, I think, need to revisit their job description currently, and also where should they be actually giving that specialist advice based on the need. And the Best Start Family Hubs might just help when those numbers have dropped, because that gives an opportunity for a holistic approach to addressing babies' needs and family needs.
Thank you very much. So I'll start by congratulating myself on my excellent chairing, bringing it right in on time. Thank you very much to our esteemed panellists today as well. And thank you very much to Impact on Urban Health for their support with this event. You've got lunch just next door. I hope to see you there shortly.
Okay. Okay then, shall we settle down? Okay, well, I hope you managed to have a decent lunch and do the thing that many of you came here to do, which is have a chat. I welcome back to the second half. For our second keynote, we are delighted to be joined by Stuart Andrew, MP, the Shadow Secretary of State for Health and Social Care. Stuart has been an MP since 2010, so he's an old hand. And has previously served as Shadow Secretary of State for Culture, Media and Sport, and in the previous government was the Minister for Prisons, Probation and the Minister for Housing. So I'm going to ask Stuart to come up, make his speech, and then I'm going to ask a few questions. Is that all right? The floor's yours, Stuart.
Well, thank you very much indeed, Victor. I have to say, I always get really nervous when it's billed as a keynote speech. It sort of raises expectations, but there you go. But I want to say thank you to you for inviting me here today, not least because it is a privilege to speak to people who do not just talk about health and social care, but actually carry it, whether it be clinicians, researchers, charities, providers, policy experts, managers and innovators who see both the promise of the NHS and the pressure that it is under. Now, I want to begin honestly. For too long, in my opinion, politics has treated the NHS as if the question could be answered by just one number. How many billions are being spent? Of course, funding matters. No serious person would pretend otherwise. Staff cannot be expected to deliver world-class care without the resources, equipment, estates and technology to do so. But we must move beyond a politics in which the size of the spending announcements becomes the measure of how much we care. Patients do not experience a billion-pound figure. They experience whether the phone is answered, whether the appointment is available, whether the test happens quickly, whether the diagnosis comes early enough, whether their pain is believed, and whether services join up around them. And that is the shift I believe we need. From announcement to implementation, from input to outcome, from what is promised at a lectern to what changes at the bedside, in the clinic, in the ambulance, in the care home and in the family living room. Now, before I entered Parliament, I worked in the hospice movement, and it shaped the way I think about health policy. Because a delay is a person who is frightened. A gap between services becomes a family under pressure. A poorly designed pathway is a member of staff trying to do the right thing inside a system that does not always make the right thing easy. That is why the question must always come back to whether the system is working for the people who need it. Not whether a structure looks impressive on paper, and not whether a reform sounds bold in a press release, but whether patients and families experience better, safer, more timely, and more compassionate care. We should be honest about the challenge. Demand is rising. People are living longer, often with more complex conditions. Medicine can do more than ever before, but that brings new expectations and demands and pressures. The pandemic placed extraordinary strain on services, patients and staff, a challenge the people in this room met. And over many years across governments of different parties, there have been real progress in innovation, diagnostics, digital care and new treatments. But there have also been persistent failures. Access, productivity, workforce pressure, social care, prevention and the gap between national policy and lived experience. The public are tired of politicians defending systems. They want us to fix problems. NHS staff do not need another initiative. You need a system that respects your time, trusts your professionalism, and gives you the tools to deliver the care you train to provide. That is the approach I want to take as the Shadow Secretary of State. My job is to scrutinise the government, and where governments are missed, where reforms are poorly designed, and where promises are not matched by delivery, we will say so. But where government is making real improvement, we will work constructively with them. That is what you all deserve from us in Parliament, because the NHS is not an arena for me for political point scoring. It is about the person waiting for treatment, the family trying to get answers, the child who needs support early, and the staff member who wants to spend more time caring and less time fighting bureaucracy. That spirit matters when people have already given so much of themselves to make the case for change. Maternity care is one of those areas. For years, women and families have told their stories. They have relived the most painful moments of their lives in reports, reviews, inquiries, and campaigns. They have spoken about not being listened to, warning signs being missed, concerns being dismissed, and care that should have been safe and compassionate falling short. That is why the Ockenden Review, announced yesterday, must be the point of real change. Too many feel that after giving the system the evidence of their grief and trauma, change has been too slow. We owe them more than sympathy. We owe them implementation. Not another moment in which people are asked to tell their stories yet again, only to see the same themes reappear in the next report. The test now is whether learning becomes practice, whether safety cultures change, whether escalation works, whether women are listened to, and whether families can see that their courage has led to real results. And that is why I have said to James Murray that I offer our help in bringing about that change, working truly cross-party to bring the urgent change that is needed and to ensure that it is a longer-term change overseen by whoever is in government. But not just in maternity. I want us to be constructive in opposition. I want us to look to the more long-term, because we can't resolve so many of these issues in just 5-year parliamentary cycles. So where we can agree and work together, I make the offer to do so, in the national interest, but more importantly, in the interests of patients and staff. Real change is the discipline we must adopt across all of health and care. Waiting lists are a clear example. It matters that figures are accurate, but validation alone is not delivery. Patients deserve to know whether waiting lists are falling because people have received the treatment they need, or if it's a simple act of sleight of hand. The measure that matters most is not a number on a spreadsheet. It is whether people are getting the care they need when they need it. The same test should apply to every reform. Does it make it easier for staff to deliver care? Does it make it easier for patients to access care? Does it improve outcomes, safety and experience? And does it prevent illness rather than simply managing avoidable demand later? That is why one of the first things I charged my team with when I was appointed last year as the Shadow Secretary of State was the creation of policy working groups, each made up of people working in the field. For example, in our primary care group, led by Dr. Luke Evans MP, we have GPs, practice managers and community nurses. In our oral health working group, led by Dr. Caroline Johnson MP, we have dentists, practice managers, dental nurses and academics. And we have others covering secondary care, social care, mental health, prevention and physical activity, and improving productivity, tech and AI, to name just a few. All have been asked to look at the key challenges their subject areas face. So the opportunities that exist and the possible solutions that help us form our policy development. I do not believe politicians should sit in Westminster and assume they already have every answer. The best ideas often come from people delivering the services and people relying on them. So our work must be practical. What needs to change locally? What data would show whether it is working? What workforce and digital requirements are needed? What would the first year look like? How would we avoid another announcement that sounds good on day 1, but fails to change experience on day 100? But I have also asked that for every suggestion or proposal they make, that they also have an implementation plan on how it will be delivered. Because if there is one thing I have heard time and time again from those who have engaged with me, is that there are good things in the 10-year plan, and I would agree. There are good things in the National Cancer Plan, and again, I would agree. But they all say the same thing. How is it going to be delivered? And so, as I was to learn from that, that is why I have asked for those implementation plans. They are going to be a key part of any policy announcement we make. In addition, I am keen for us to work with other shadow teams on things like the life sciences sector, making the UK a great place to invest and working out how best we get patients the best medicine available. And given my background in the charity sector, I want us to look at how we can better collaborate, to partner. So much incredible work is delivered by the third sector. Just look at how they helped mobilize the community response in the pandemic. Look at the amazing end-of-life care our hospices and charity nurses provide. But too often, it seems to me that charities are only invited around the table when it suits. And that seems a missed opportunity to me. So I will be doing some more work to see if we can do things better. It seems to be that it is better to work together than separately. So I hope that I've been able to demonstrate to you that my team and I are taking this brief incredibly seriously. We are doing the groundwork, but if you want to be a part of it, then please let us know. We want to hear your thoughts, your ideas, and your suggestions. For me, the standard we should set ourselves is a system focused on patients, families, and outcomes. A system that backs professionals, a system that embraces innovation where it improves care, a system that sees prevention, early intervention, and social care as essential to the NHS, and a system that remembers compassion and dignity are central to quality. That is the approach that I will take, listening seriously, scrutinising fairly, learning constantly, and focusing relentlessly on the people who matter, patients, families, staff, and all those who rely on care. Thank you.
Thank you. I think that was a keynote speech, don't you? I think that was a pretty keynote. That'll do. Just what did you do when you were working in hospital?
I wasn't a clinician.
No, that's not. I'm just curious.
I was the head of fundraising.
Oh, right. Okay. Okay.
I worked mainly in children's hospices.
Oh, right.
But I did work in an adults hospice as well.
Okay.
But what it did do, because we were very much a team, you know, actually everybody recognised, I couldn't do my fundraising without the care team doing their work. So you would work very much together as a team, and actually meeting the families, I think, was the thing that really changed my life.
That's really good. So let me ask you a couple of things. So the last government got us, well, managed to drag the country through the pandemic and a couple of other shocks that were kind of unplanned. But we did leave the last government with kind of record waiting lists. The public decline in the NHS was well on its way. And I just wonder, what is it that you think that your party needs to do to kind of regain trust, want a better term? And also, just like, how do you, in hindsight, so what were the things that you got right during that period? You know, like, because it's easy to focus on the negative. What do you think you got right?
So, look, I mean, I'm one of those, I accept when mistakes are made, because if you don't accept that, you're never going to learn from them. And I think that is a key part of what we are doing. It's why I also want us to make sure that we're not just focusing on that issue about how much money you put into it. It's what is it actually delivering?
Helps, though.
Of course it does. Of course it does. I'm not denying that. But what I'm saying is, you know, look at what this government have done. Put in, you know, many billions extra. are people saying they're seeing the equivalent, improvement? And that's what I'm hearing. Exactly.
But there has been an uptick in public opinion.
Yes, of course there has been. And, we will learn from that, absolutely. That is why these policy groups are so important to me, because I actually don't want it to be just some, conservative-leaning think tanks and a load of our MP colleagues.
That's really refreshing to hear that,
I want to hear from people on the front line, and what I'm finding is that there is that, I've been really pleased by the positive engagement we've been getting and the frank discussions, because I've said to them all, Chatham House rules, nothing is going to get back. I want to hear it warts and all, and where we made mistakes and where we could improve.
So just say a bit about the difference between what you're hearing now and the mistakes that were made. I mean, what are people telling you? You don't have to go into chapter and verse, but just the key themes, and then what are the mistakes?
Yeah, well, the reason I mentioned the funding side of things is because that's what people are telling me.
Yeah.
They're actually not seeing a material, they're seeing some improvement, yes, of course, but not to the level that you might expect. And I think that issue around how you implement plans is a really big issue for people. People are saying really positive stuff about some of the stuff that's in the 10-year plan. That move from hospital to neighbourhood is great, but how is it going to do? How is it going to be done? And crucially, who's going to do it, particularly in a moment when we're going through reorganisation, with the ICBs and the abolition of NHS England. A lot of what local delivery partners are telling me is that they're struggling to find the person who's going to lead it for them locally.
Would you have abolished NHS England?
Do you know what? I'm not opposed to it, actually. And we have said that the health bill is going through Parliament at the moment. We're supporting that. But what we want to make sure is
so it's a necessary change in your...
I think so. Look, I mean...
Was that one of the mistakes, setting it up in the first place?
Probably,
I'd agree with that. I'd agree with that. So much of what we've talked about this morning wasn't just about the NHS, it was about the health system, the idea that you can't have wealth without health, which impacts on many other areas of public service. So I'm curious about what the Conservative vision, I guess, it's not just the idea of the NHS, but the idea of the NHS in the context of public services more generally. I mean, given that your party was the party of austerity, let's just be honest. What's the vision that you might offer people of the NHS in the context of the wider public service?
Well, I mean, I think first of all, we've been saying all along that we need a strong economy if we're going to have strong public services, because ultimately it's that income that pays for all those services. And I am worried about. I just think about my own constituency. And I think about the small and medium-sized businesses who are really struggling at the moment because of the added burdens that have been put on them recently. And the reason why I'm worried about that, I'm worried about that for those people and their business and their income. But I'm worried about how much we're going to get in for those services. So that's why I'm working very closely with our shadow Treasury team, with a shadow business team and science and technology teams, because there are things that we need to do to work together so that actually that it creates the environment where there is more money coming in through taxation, because actually the economy is going.
Okay, so that you would grow the economy. I just want to, before we go out, I just want to ask you about inequality and inequity, because if you go to the poorest areas of this country, you will see that people aren't able to work because of their mental health and their physical health problems. You see that those people are actually costing the NHS, they're using NHS services. And your party has generally had a negative view of welfare reform. How do you square that circle between focusing on inequity and inequality generally across public services to decrease the demand on the NHS and cutting welfare?
Because actually it's about addressing it in a different direction. So where I grew up on a council estate, I saw people who were not working, their health getting worse and worse and worse, and those that were helped back into work, their health improving.
Okay.
So that, I think it's important that I then also work with the shadow DWP team. Okay. It's not just about cutting welfare, it's about how do we get people back into work so that they're not then relying.
So would you agree then with Alan Milburn's approach, which is, honestly saying, actually, we're spending more not helping people, young people in particular, getting into work than...
Yeah, I mean, I'm really worried about the number of young people who are struggling to find work at the moment. I mean, I was talking to a local pub owner in my own constituency, who for years has run, his business model has been that, you know, the sort of 14-year-old growing up in the village would do the posh, you know, the pot washing.
Yeah.
Then they'd be a waiter or waitress, and then behind the bar, and then when they went to university, they had staff at the peak times they needed them when they came back at summer and Christmas. He can't afford to do it anymore because that minimum wage has gone up so much, and the taxes he has to pay on national insurance contributions has meant. So I do worry about opportunities for those.
I always have this thing about minimum wage, because what is the minimum?
Well,
because in theory, not paying people at all would employ everybody, wouldn't it?
Yeah.
So it's like, okay, so let's put this out to we'll take 3 at a time, and then we'll come back to Stuart, who's been very kind. Chap in the black t-shirt. If you say who you are and where you're from and keep it to a question, that'd be great.
Hello, Rydian Hughes from the voluntary organisations Disability Group. Really pleased to hear your commitment to the third sector, so thank you for that. My question's on adult social care. What's your vision for the reform of adult social care? And can I also ask how you're working with Baroness Casey on her reforms? Thank you.
Thanks. Okay, let's take one more. Let's go over here. There's a lady there with hand up. Keep your hand up. It's coming to you.
Hello, Sophie Martin from Spire Healthcare. We are a provider of services, hospital care and other care, and last year we treated 200,000 NHS patients and took another 800,000 patients treated privately who would have been on an NHS waiting list. It's great that you want to get voluntary sector around the table. What about getting independent healthcare there too, to have wider conversations about system working?
That's your private sector organisation, aren't you?
Correct.
Okay, just wanted to check. And yeah, we'll go. Oh, he's right at the back. Okay, go on then. The chap at the back, people at the back don't often get.
Thank you, Stuart. Sean Walsh from Cancer Research UK. Absolutely agree with the points you made around welcoming the cancer plan and the importance then seeing what an implementation plan looks like to deliver a plan in practice. My question was around the prevention agenda. Rishi Sunak took the brilliant and bold move to introduce the Tobacco and Vapes Bill, which was then delivered by the new Labour government.
Yep.
Could you outline some of your thinking around prevention and particular actions around childhood obesity?
Great question. So you've got 3 questions there. One is about commitment, your vision for health and social care, and particularly your interactions with Miss Baroness Casey, and then we've got our friend from Inspire there, and how you're going to work with the private sector. I don't use the word independent, because in a democracy, we're all independent. From the private sector, how do you work with that? And then the cancer plan and prevention. Take any one of them.
No, okay, so on the adult social care thing, I mean, look, I've engaged with the KC review fully, and, you know, really want us to find where we can have that common ground cross-party, because again, this goes to that point about we can't solve this in 5 years.
Yeah,
There's just no way, you know, and let's be honest, this has become such a political minefield that parties, and I get it, have sort of like, I don't know if we can touch this because it's so poisonous. And I almost know that from very personal experience, because when Theresa May, you'll recall, in the manifesto in 2017, tried to come up with a solution, I nearly lost my seat because it killed us very, very quickly. So I do think the Casey review is an important opportunity, and I have to say I pay tribute to her because the approach she is taking to it, I think, is absolutely superb. She even came to my constituency, met with people locally, was seeing the services on the ground. You know, her team are working incredibly hard. My challenge, though, is that the date that she's got to report by is scarily close to a general election. And my worry is that, and I know she said she's going to try and announce things earlier if she can, which is great, but that ultimate, you know, what are we going to do?
Political thing.
I think, I'm being really honest, I think it's going to be so close to a general election that it won't happen. And that's my worry.
But do you have a vision for social care yourself?
At the moment, no, because we're doing the evidence gathering. We've got the social care policy group ourselves, and they are in the early stages of, taking ideas that many others have brought, whether, and there's a whole host of different suggestions people are bringing. Things like, should we have a national social care service rather than leaving it to the local authorities?
Yeah.
Those are the things I want to look at and explore in detail, but really base whatever we decide on the evidence and how it will fit in with what Casey eventually says. So, I mean, it's a massive, massive piece of work.
Yeah.
So I don't want to pretend I can give you, the solution right now. In terms of independent private healthcare, I have had quite a few meetings. In fact, the local hospital, I think it is one of your hospitals in Northampton, I went to recently. Look, my view is that if we can get patients the treatment they need, then we should do so. And to be fair, if I'm being really honest, it's probably mainly Labour governments in the past that have been bold enough to do that. I just want to make sure that patients are not suffering for a long time.
Yeah.
And I do get that there are caveats with that. We've got to be, people want to be careful and mindful.
Value
that
for
it's
money,
not exactly. And that's always got to be.
I mean, did you ask that question because you're not getting what you want, or because you're dealing with 200,000 people? You're doing. I mean, last time I looked, you're doing okay. What is it that you'd want him to do that isn't currently happening? I'm just curious. Yeah. Have we got a mic, just so that you can... I'm just curious.
We and other independent providers are seeing changes to NHS commissioning so that ICBs can stick to their budgets. And the commissioning rates are lower than they were in the past, so there are patients who could be treated who are not.
Yeah, and that's what I'm hearing from, if I speak to constituents in my area, that is happening on the ground. So where before, there was the treatment was happening by NHS hospitals, but also NHS commissioning private. That's just not happening as much, so that's why people are waiting longer, I think.
So your issue is that the private sector isn't being commissioned. I just want to get to the last question.
Worth noting that we're paid exactly the same as NHS Trust, so it's not more expensive.
I do know that. Right. Yeah, thank you. And the last question.
And then on prevention, in the previous government, I was the sports minister, and one of the things I did there was set up a national physical activity sports group, and that was to try and bring all government departments that have a role in prevention together. So bringing education in, bringing in the health service, bringing in DWP, and all the national sporting bodies and the private sector, so local gyms on your high street, to see what we could do to get the population more active. And I saw...
the question was specifically, though, really, around about obesity and which is
that's
about food quality and stuff.
No, I think
not
actually,
just about exercise.
But it's a big part of it.
It is.
And the problem is the activity rates, the physical activity rates are stubbornly sticking at the same level. And my worry is that particularly, and this is why we're seeing it in some younger people, is because there are things that stop, say, girls, for example, when they get into their teens. There are
I understand
issues
that.
And so what is it that we can do to make...
But are you saying you'll do nothing about food and sugar?
No. I mean, we brought in the sugar tax.
Exactly.
And, one of the things I've learned about that is, industry was saying, oh my God, this is going to cost us a fortune. Well, actually, the sugar tax hasn't brought in much money.
So would you do more?
Because they changed, and I've challenged industry, because I am meeting with them quite regularly. Where I have challenged them is, you said before you couldn't do this, and then you can. And I think in fairness to them, they are starting to realise that they probably handled that badly.
So would you do more?
But again, we've got to look at that. The prevention agenda is one of those, as I mentioned, of our groups, and the food, physical activity, all of that will be part of it.
Sadly, I'm being told that we've run out of time because you've been so comprehensive in your responses. No, and the questions have been fair. Can we just thank Stuart for his Thank you very much. That was very good. I'd like to come and see you as well. And can I hand over to Seb for our second panel? Oh, Seb, and what a wonderful thing you've done. I mean, what a great great event. A little round of applause for Seb. I think he's done really well.
It's just a bit of a change of furniture. I'll drag this one here. Oh yeah, sorry. Need one more. Sonia, sorry, I don't even introduce myself yet. Lovely to meet you.
That's it, lovely to meet you, Sonia.
How are things?
Good, just not complaining. It's lovely weather.
It's perfect.
I'm a little bit more cash. I have my jacket on. I was like, cannot wear it.
That's right, I can wear my jacket either.
Hi, Sonia. Hi, Sonia. Nice to meet you.
So for sake of ease, we're just going to go across the panel like this. I'll come to you first for opening remarks.
Okay, so I'm going to talk a little bit about my idea about how like a health biosphere, looking at health from an early age all the way to like working life, how we get more people into work, a little bit about Dudley and myself, hopefully 5 minutes. Yeah?
Wearing a blue sleeve shirt.
Well, it's kind of like a picture of my idea.
ditched the
As well. Oh
jacket.
my god. I'm going to have a nice glass actually. Is that sparkling?
I'm not sure. It's whatever was.
Yeah, that's looks sparkling, I think.
You okay with this one?
Yeah, that's fine.
Some
water.
Yeah, please.
So warm as me. So, thank you.
Tom. Brilliant. I think we are good to go. We've made it to stage 2 of the life course and to the vital middle of the conference and also the panel entitled The Vital Middle. And this panel is all going to be about health in working age. As many of you will know, IPPR, for many, many years, one of the big areas of focus for us has been on the connection between health and wealth. Through our Commission on Health and Prosperity, we socialised or mainstreamed a lot of the thinking around poor health and our poor economic performance as a nation being fundamentally connected. And I think it's fair to say that in the last few years that agenda has become even more mainstream, a very central subject of conversation for government, embodied recently in the Mayfield Review on Health and Work, and also in the review chaired by Alan Milburn on young people who are NEET. This panel's an opportunity to take stock of where we've got to with the health and work agenda, but also to talk about what opportunities there are to accelerate that agenda, and perhaps even to talk about where we might need to think differently or do things differently. I know that we're having this discussion in a relatively tense political moment, so we're also really interested in how we keep this agenda going through somewhat turbulent times. And with me to discuss this today, we've got a brilliant panel. So firstly, Sonia Kumar MP. Sonia is a PPS to the Cabinet Office. She's been the Labour MP for Dudley since 2024. She's a tireless campaigner on health issues, both before and after becoming an MP. And she's also, by background, an NHS physio, and we know what a huge contributor musculoskeletal conditions are to issues around health and work. Secondly, we've got Nicola Smith, who's the Director of Policy at the TUC, where she leads work on economic and labour market issues and employment rights. She's also a Commissioner on the Health Foundation's Commission on Healthy Working Lives. Thirdly, we've got Chris Smythe. Chris is the Public Policy Editor at the Financial Times, where he covers public services, including welfare. He was previously the Times Whitehall Editor. And the eagle-eyed amongst you will have noticed that we don't in fact have Sarah Hughes from Mind here, but we have a very worthy replacement in Tom Pollard, also at Mind. Tom's the head of policy and public affairs and campaigns at Mind. He's advised the Department for Work and Pensions on mental health policy. He's also a trained mental health social worker. So I'm going to keep quiet after this. I'm going to pass it over to Sonia for opening remarks.
So good afternoon everybody, my name is Sonia Kumar, I'm the Member of Parliament for Dudley. I'm an NHS physiotherapist, so working as an advanced practice physiotherapist and first contact practitioner in the NHS, so very much well versed of how to get people back into work and also how do we keep people healthy in work is one of the key things that I've been taking up as a physio and then now as an MP. The work that I've done, it covers sort of the APPG of allied health professionals, so looking at the full team, That includes speech and language, occupational therapists, paramedics, all the workforce, which carry about a third of the workforce that people don't talk about. So we talk about doctors and nurses a lot about looking after people's health and well-being, but they never talk about advanced or health professionals and AHPs, which they carry a third of the NHS clinically. Now, not just that, I've done some work in Ukraine, so I took out some clinicians to train this year in February to sort of work up their civilian workforce and also those that are working on the front line. So having a look at not just at healthcare in the UK, but looking at other places and comparing. So I think what I really think we need to be looking at when we're looking at keeping a healthy lifestyle, it needs to be starting at early years. I think people just think straight away that you have to think about work, health in workplace when they're at work. But some of these things start at very young age. Now, with Alan Milburn's report, we know if you are 3 or 4 years old and your life chances, what your expectancy are, whether you're going to have inequality, whether you're going to get a job, and how likely you're going to get a job, starts at such a young age. So an idea that I've sort of coined is what's called the health biosphere. So we're not just looking at health at a fragmented and in silos, which is what we're doing at the moment. So we're building services for people depending on, what that service need is. It's not about services, it should be about patients. It should be about people. And that's something I think is a missing link at the moment. The government's policy, I am a PPS, so I'm going to be talking pro-business and pro-government policy on here, so do pardon me here, but of course I will be as a PPS. But the great thing we are doing is looking about healthcare into the community, and that shift is absolutely essential if we want to start funding primary and secondary, over secondary care, needs to start first of what's in the community and what we need to do. So the health biosphere, the sort of concept that I think we should be doing is looking at mapping assets and community services across not just one area, but the whole entire borough, then the whole entire country. So where's your green spaces, where's your high streets are, where's your community centres, your family hubs, if you've got any services, like specialist service, like fracture liaison services, so that is for shout out for Tom, who's at the Osteoporosis Society. So looking at everything you have there, mapping out the whole entire community, because if you know that you've got high levels of inequality, because demographically you've got multiple people in houses, you've got low life expectancy, then you're more likely to then provide services to that area for that population. And it's happening in some places, but it's not happening at a standardisation across the whole entire country. And we're not going into the deep diving data of this. So when I think about the higher health biosphere, I'm looking at all aspects of health, including like green spaces, including demographics, using data and AI to actually give us an incentive how we're going to match up services and care. If you have a borough or an area that has high levels of more mature patients, you're more likely to need a fracture liaison service, you're more likely to need complex care, you're more likely to need all sorts of sort of high level care than you are when it's a younger generation, younger population that's more affluent. So you've really got to match both services and care. And that comes back to the workplace, because if we actually manage the population and the services there, therefore people are more likely to then be referred to the right service at the right time with the right clinician, and we're going to keep more people into work. And if you don't fund primary care, then you can't do that. Now, it's not just the NHS that I feel like needs to be a part of that, and the local government, its charities, third sectors, all of the community needs to be buy-in on this health population background, and then also then requires businesses to then feed into this. So I think at the moment we've got a very much fragmented care for people and getting good care for people that are in work and keeping them into work. So if you've started a job and for unfortunate reason you are unwell, getting in to see an occupational therapist for a simple thing like musculoskeletal conditions should be the first thing you should be able to do. You shouldn't be doing a 3-month wait to see a physiotherapist or an occupational therapist. And then the longer you're out of work, the less likely you're going to contribute. We've got 800,000 people at the moment that have got a health condition, we've got 1 in 5 NEETs. We wouldn't have this problem with workforce if we had a healthcare system, both mental and physical health in parity, and actually services that are actually linked to the patient population and are mapped out with using what we already currently have, which is data and analytics. So that's my opening of what I think needs to happen, and I'll hand over.
Okay, thanks very much. I'll try and speak as loudly as I can. So I suppose I should start by saying it is really welcome from the TUC's perspective to see this focus on improving health and work, and to sort of recognise the scale of some of the labour market challenges that have simply gone unspoken or unaddressed for such a long time. The Mayfield review set out very clearly that we've got 1 in 5 working age people out of work and not looking for it, and that is much higher than many other comparator countries that are doing much better than us, including the Netherlands, Sweden, Denmark. There's obviously an impact on the growth rate of having, still a relatively high employment rate in this country, but having lower levels of labour market participation than we could do. And that obviously also increases spending on out-of-work welfare, which could be better spent on good quality health services and support. And I think one of the most worrying figures from the Mayfield review is not that we've got such large numbers of people economically inactive and out of work, of working age at the moment, but the forecast for what is set to happen to those numbers if nothing changes. And they're set to almost double by 2030 if current trends continue. A really important fact, I think, in this debate is that when people have left work for economic inactivity, it is very, very unlikely that they return. I saw analysis that was published recently that shows it's something like 1 in 40 people, when they leave work and are economically inactive for a period of time, will return back into a job. But also what I know is that that's been a relatively consistent factor over many, many, many years. But what has changed recently is that the flows from work into inactivity have sped up. So we've got a problem of a larger number of people at work who are working, 8 million people now, with conditions that limit the work they can do in some way, and more rapid flows from that work into economic inactivity, which people then don't leave. There's so much going on here that we could talk about, and I'm sort of conscious that I could probably take up the whole panel with going down whichever one of the drivers you want to look at. But my sort of short version is you've got to remember how complex and multifaceted the drivers of this problem are. We've got young people who've been left without support for years, who've got higher levels of mental ill health and are not engaged in any sort of meaningful activity, and that is not available for them. At the other end, we've got older women who have got a rising state pension age, a higher incidence of ill health and large amounts of unpaid care. There are very, very many different population groups for whom the causes of economic inactivity and ill health are multiple and different. I suppose from the TUC's perspective, one very consistent trend is that job quality really, really matters. And if you want to keep more people in work for longer, and if you want to make sure that you can see employment rates rise, you have to have better quality jobs where people are able to receive more support, and where the expectation is that you remain in work when you are in ill health or where you have a disability, and that there are standards and a level playing field that will mean that those cowboy employers that don't want to treat their staff well aren't undercut by others. There's lots of evidence on the link between job quality and health, and we're very conscious of the detrimental impact that bad jobs can have on health, as well as the positive impact that good jobs can have on retention. So there's probably a lot more to discuss in the rest of the session. I think I'll probably leave it there, but from our perspective, getting on with that Employment Rights Act, getting on with that full plan to make work pay, including the disability pay gap, reporting and action plans, commitments in there, is really a central part of this challenge and needs to be front and centre of a government response to improving health at work.
Chris?
Well, I will just sort of, I suppose, try and give a bit of political context to all of this. And I think the trend of worsening health, particularly amongst younger and working age people that we've seen in recent years, I mean, especially since COVID, but it does predate that, is quite profound and really, a major challenge for any government. I mean, any government that is trying to restore growth, says that's its number one goal, is going to struggle if a big chunk of your working age population can't work, and an even bigger chunk is struggling in work. Obviously, that manifests itself most immediately in the welfare bill, but it does longer term in the economy and society that can have a decades-long scarring effect. And to be honest, I was quite surprised when this government came in, it didn't immediately say, we need to understand this better. You know, there are lots of different causes, lots of different competing explanations, and I don't think anyone has really developed convincing evidence of exactly what's going on. And you know, if I'd been chancellor, I would have said, we need to understand this, we need to have a proper deep dive into it. Instead, what we got was them waking up to it at some point last year and thinking, oh my God, we need to cut the benefits bill. We all saw how that went last summer. I mean, that was, you know, a disaster on many levels. Politically, obviously, it, you know, precipitated Keir Starmer's downfall as Prime Minister. You can all have your views on whether or not that's a good idea, but it's pretty bad news for him. And I guess on a policy level, it has really put a chill on trying to do something about work and health for quite a long time, made people quite reluctant to get into that area. I mean, I think we are now starting to be in a better place in terms of where we go here. We've got a couple of, you know, several reviews going on. There's the Mayfield review, which is about how, you know, Nicola said, you know, a lot of people are out of work. The bigger problem is people are in work and at risk of dropping out. What do you do about them? You know, Charlie Mayfield is trying to come up with some sensible things that employers can do to help people in that situation. He's done a lot of good work. I mean, I think the difficulty is the logical place that is going to lead are incentives for employers to do things, whether that's, you know, the stick if they don't do it, or the incentives through the tax system for providing occupational health or whatever. But because of the political context, this government has obviously put up employment you know, taxes a lot. He can't really recommend that, so he's taken the pragmatic decision to try and develop some standards, get some employers on board, hope that that provides proof of concept, and then we can have that debate about how you incentivise employers to do it. And then we've got Alan Milburn's review focused on young people, and I think he has done that classic public policy thing of building a case by setting out the problem and seeing that no one disagrees with that. So then you set out the range of solutions and you see if no one disagrees with that, and then it becomes much easier to bind people in to the recommendations he is going to make fairly soon, even though I suspect he probably already knows what they are. And with Andy Burnham coming in, I mean, I think there is a moment here to try and do things better. As you know, he's obviously a passionate advocate of devolution. He has talked about trying to join up health employment support locally. He wanted to take over job centres, you know, in Greater Manchester, so he could focus them more on people with health problems. I'd be very surprised if he doesn't suggest that as a policy lever. So plenty of big opportunities there, as well as what the broader welfare system can do. He's obviously talking to Alan Milburn, and there is, you know, amongst those MPs who objected to last year's proposals for understandable reason, there is now a desire to come up with a better set of welfare reforms that is more focused on support for people with health problem and trying to get people back to work in that way. What those will look like and how you pay for them in the short and long term is, of course, a very big debate that I'm sure we'll be having in the coming months.
I'll pass over to Tom for final comments.
Yeah, hi everyone. Sorry Sarah can't be here. Combination of heat-related childcare and travel issues kind of put paid to that. I'm going to read a bit more from my notes than I'd like to because I only found out I was doing this 2 hours ago. But so mental health has been like front and centre in this whole debate, and that's partly because the data suggests that mental health has been like the fastest rising cause in a lot of economic inactivity and associated benefit claims, particularly for young people. But also I think because mental health, along with ADHD and autism, has become a bit of a lightning rod for a narrative suggesting that rising rates are being driven in part by kind of shifting conceptions of what constitutes a mental health problem, this kind of overdiagnosis narrative. And at times, within the benefit space, this narrative is blurred with kind of tropes about the motivations and character of people on benefits, and in its kind of more ugly manifestations, has basically suggested that there are people out there kind of using mental health language to kind of avoid work, or to try to get benefits. And in some ways linked to that, the government commissioned this independent review into the rising prevalence of mental health problems, ADHD, autism, and the interim report that came out recently suggested that kind of rising levels of distress, often meeting kind of clinical levels of mental health thresholds, are very real, and that the current model of support is not able to meet that rising demand. But it also acknowledged that there have been shifts in how people talk and think about mental health. People may be feeling more able to be open about struggles they're experiencing, but maybe also more likely to have a kind of medical lens in how they understand and think about that. And I know from frontline practice that I do that there is a real difference in how young people talk about mental health in many cases compared to older people. But I think it would be a big mistake to conclude from that that's simply about needs being overstated. It's much more complex than that. And the evidence suggests that there are complex reasons for increasing levels of poor mental health, many of which, as Chris was saying, predate the pandemic, so a kind of range of social, economic factors, including experience of work, but also access to health support. And when we're thinking about this debate, it is much more complex than mental health. A lot of the narrative has been about people being off work or on benefits because of anxiety, which firstly belittles how disabling severe anxiety can be, but also the reality is far more complex than that. Most people in this situation have multiple long-term complex health conditions. And that reflects a kind of fundamental challenge in the health system, right? That we have a system that's often designed around an assumption that people present with kind of a discrete condition, and that can be diagnosed and treated, and you kind of send someone on their way. But the reality is that now a kind of large and increasing proportion of people presenting to the NHS are doing so with multiple complex, often chronic, conditions, often with mental health in the mix, and often partly driven and definitely complicated by social and economic factors. And so a critical part of how you respond to that, we think, is this idea of kind of creating much more listening capacity, particularly at kind of an early stage in the NHS, so that people can feel heard, can feel kind of held and validated, but also that you can better understand the challenges they're facing and make better decisions about the type of support they need. So linked to this, Mind is calling for a shift towards what we call a same-day open access model of mental health care. And this was proposed by the previous Labour administration in Wales, which basically says you need to move away from kind of very tightly gate-kept mental health services and pathways and towards a system that allows people to access a really good conversation about their mental health, ideally on the day that they need it. And that conversation explores their needs, tries to address kind of immediate challenges, but then directs them onto the longer-term support they need. We'll be setting out our proposals for this kind of open access model in the summer. We're also going to be supporting a strand of work within IPPR's new programme on building community-centred health system, which we hope will support this shift. And that's about how the health system responds to this, but I think that has been underplayed a little bit in some of the benefits debate, the importance of health support, the kind of idea that there's a lot of overdiagnosis and maybe if you just get someone into work, that will sort it out. But also, this open access model we're advocating would help people to access a range of support, whether that's about employment, debt, other things as well. And I think we'll get into questions now about jobs and the workplace and the benefit system. But I think this response of prioritising really high quality initial engagement with people to build trust and understanding and respond appropriately is critical to those spaces as well. And finally, lots of policy work in this space kind of acknowledges the importance of things like relational support, but it really fails to get into the detail of how you design and deliver that and maintain it over time. And it also fails, frankly, to recognise that there are really real trade-offs. So if you have a system that is transactional and sometimes coercive, as the benefit system can be, that directly impacts on the quality of relationships you're able to build, and we know those relationships are critical to help people progress.
Brilliant. Already a huge amount in there from panel, so I'm trying to work out how to direct a huge number of threads. I know that people want to come back on specific points, but I had a few framing questions which people might be interested in tackling. The first one is just about the model of support that we have. So I think sometimes we talk about this issue like it's a capacity issue in the NHS or a capacity issue in DWP around just resources going into dealing with work and health. I think there's a deeper question, which is about whether we have the right services in place, whether they're designed appropriately to meet the needs that we have. So I'm very interested in people's reflections, and it came up actually in Sonia's remarks about the fact that you have to wait 3 months to have an occupational health assessment. If you were to put that at the front of the process and make sure that people had a really good first interaction with that service, maybe that kind of changes the dynamic. But interested in people's reflections on service design, both in terms of what health services are doing, but also in terms of the kind of support that we have in workplaces at the moment. Is it really fit for purpose in terms of some of the health challenges that we're talking about? Second big question is about machinery of government, and I know many people on the panel have spent time in and around Whitehall, but just thinking, do we have the right structure in place to have a really productive relationship between the two most important departments here really being DHSC and DWP, but also business and trade, the Department for Education? Do we really have a kind of properly joined up approach in this area? But also mirroring that at a local level, what do those kind of relations look like between local authorities, local NHS systems and local employers? as well as the kind of formal how do departments and parts of government talk to one another. Also a question here about engagement with employers, both big employers and SMEs who employ a huge number of people. Do we have productive conversations about how we can solve this in a joined up way? And then the final question is about best practice. Would love people to have some positive case studies and examples of how we do this well, both here and internationally. So if anyone wants to jump in on any of those questions, I might start with Sonia.
So in terms of services, do I feel they're being built according to what the population needs are? No, not yet. A lot of the funding's going into secondary care over primary care, and you need to have two tracks going at the same time to maintain what we've got going on and manage the backlog of referrals, of operations and consultants appointments that you need. But then you also need to fund at the same time community-based and build some resilience in that area, so that when you're referring someone in, it's then, okay, we're hit straight to see, potentially a specialist when you first come and see a first contact practitioner, which could be a physio, it could be a podiatrist, it could be a paramedic, and then going over. So access is definitely a key part of the issue we need to be dealing with, and services. But what I will come back to saying is, there is maybe a little bit of a turbulent time at the moment, but doesn't mean that the agenda is not set. We hit a manifesto that is talking about getting people back into work. So there are pilots being done, and from a DWP, because I speak to Pat McFadden being a neighbour of mine, only in Wolverhampton, I'm the Dudley MP, about getting that access as soon as possible. The MPs are having engagements with their local communities in terms of how we get a plan, especially for those places with high levels of needs. I've got 1 in 5 in my constituency, it's ridiculously high, and how we can level up with the DWP, the NHS Health in terms of mental health, businesses, third sector, all coming together to say how can we build a system that's a lot more resilient and has the capacity to deal with complex needs. Because normally when someone comes in, they don't come in with one problem. It's normally a multitude of things. They've got poor housing, they've got a terrible situation going on at home, they might have domestic abuse. There's so much going on that actually, because of the complexity, especially highly deprived areas, you can't just see, I'm going to see DWP, they're going to give me an interview, show me how to do a CV, and that's it. It's never that easy. So building hubs and places where you can see multiple agencies in one place, I think is absolutely key, which is again coming to the shift with the government's ideology, moving to the community is absolutely essential, away from the hospital, and digitalisation. The digitalisation of the NHS will be so key, so people can see a lot of things in one place, instead of just saying, okay, one trust is doing something else, the other trust is doing something, yes, repeat the bloods, yes, repeat the imaging, and then people don't get seen. So I think this government has been really proactive of working cross-governmental, so whether it's Peter Carl, whether it's Pat McFadden, or whether it's James Murray, of how we manage this problem. So access is definitely a thing, but we're also looking at the education part of things. So when we're doing modules now to try and get more people into work, so as we've got an ageing population, which no one's touched on, we want to keep people in work for longer and healthier and having a better quality of life. And then when you're towards the end of your career, that you can then be looking at retraining potentially. So the skills that you have on manufacturing, you could be a teacher, So there's single modules that the Education Secretary Bridget's done to get people back into work. We have got incentives of SMEs, any under 25, the apprenticeships are now free. So there are incentives that are crossing multiple departments. It's not a single department's responsibility to make sure that we give back to the Treasury ultimately, so we have more people contributing, and also helps with their self-esteem and their self-worth, which is so essential what work provides.
Nicola, on any of those questions?
Yeah, so first point would be for me that we can't discount resources. We all know it is more than that, but I think if you look at the state of mental health provision, for example, and you look at even where it was back in 2010 and where it is now, it's clearly on a shoestring. I've got friends who work in clinical psychology who've gone from running one-to-one sessions over a year with people with serious childhood trauma who are now unable to offer because these people don't meet a threshold, or they're told to do 4 group work sessions. So, I think it's not particularly popular to say that resources remain a challenge, but they do remain a challenge. More money is going in, but the scale of the challenge there, I think, can't be understated. That said, of course, there are systems that could work a lot better. We have got a lot of oversight of what's happening with access to work, which many people will know is the government service that provides support run out of DWP to people who are in work. There are real improvements that could be made in the terms of how that service works, how quickly it's able to get support to people, how the assessments operate, and how we stop services that should be being paid for by large employers who can afford it in response to their reasonable adjustment duties, and refocus that service on perhaps other employers who are less able to afford the adjustments and might be better able to benefit from access to work. So I think that would be an example for me of a sort of structural change you could make. I suppose on the join up, I would love to see an absolute cross-government priority on addressing this challenge of young people who aren't in education, employment or training, because I think it's the responsibility of every department. And I think, as you have said, the scarring impacts, the life chance impacts for those kids now and into the future and their families are too significant not to take that sort of approach on. And one very obvious area for me that more could be done on is on public procurement and on a sort of cross-government approach to ensuring that every contract comes with conditions, and some of those conditions are to do with jobs, and the beneficiaries of those jobs have to be those kids who need them. And I suppose, finally, on good practice examples, well, you know, I defer to the Mayfield review, but I do think in their discovery report, the examples from the Netherlands, I think it is pretty salutary. You know, you've got much higher rates of retention of people in work there, and why is that? It's because employers, if they want to sack someone with a disability, have to keep them on the payroll for 2 years and pay them at 80% pay or some such. There's a higher floor of employment rights and there's a higher set of expectation alongside a much stronger support service. So I think that is a really good example that evidence is not somewhere we can get to immediately, but why this balance of proper incentives alongside proper support is what really works in shifting workplace culture and behaviour.
Yeah, I mean, I guess on two of those points, there's the sort of capacity issue, and obviously resource, and I would say probably health is too dominant here. I mean, resources in the NHS are never enough, but it is better resource compared to most other public services, and it is a hell of a lot more visible. So, people know where their GP is. They've no idea where to get other kinds of help from, really. And I think that impacts this debate about, has openness about mental health gone too far? And I think there's a better way to look at that, is it possibly has gone too narrow, in that people are experiencing this real distress, which has lots of causes, their job, their relationship, debt, addiction, whatever it might be, and most of the time the state sort of shrugs its shoulders and like, well, we don't know what to do about that. But if it's conceived of as I've got a health problem, then suddenly there's a way, you go and see your GP, there's a pathway, a treatment, and it is much easier to respond in that way, and perhaps pushes people towards that model when other things might be done better. And in terms of joining up services, I mean, that is always the problem in the way we set up government, is it's very hard to make departments talk to each other. I mean, there's a traditional Whitehall sort of perhaps answer to this, in that, NHS integrated care boards are being set targets to get people back to work. So you could obviously say, well, you get to keep a share of the savings for that NHS region if you reduce the benefits bill or whatever. But I think the more likely way, and more interesting perhaps, given Andy Burnham coming in, is to basically devolve it all, just devolve as much as possible and say, sort this out locally, where the employers, the local problems, the health services, the employers locally. And I think that will work very well where there are good people, good relationships, and you can see some really good things coming out of that. The flip side is, where it doesn't work, things are probably going to get worse in some way, and there will be more variation. The question, are you willing to tolerate that for the price of seeing areas that do it really well?
Yeah, just quickly on the point about resourcing. I mean, NHS spend has gone up. Mental health as a proportion of NHS spend has been falling. And I think that's a very real issue, and you can't get away from the fact that if you have a higher caseload because there's less resource, right, the quality of the care you can provide to someone when you have 30 people in your caseload is just significantly worse than the quality of even if you've got 25 on. Those things really matter. And that brings me on to the main point I wanted to make, is that I think a lot of policy thinking is based on Whitehall in particular, really struggles to design the stuff that matters. Like, we know within mental health care that it is like relationships that are the critical ingredient, and they are impacted by things like resourcing. But I always have this thing I come back to. When I was on secondment at DWP, we were having a chat about how can you make better engagement, how can you improve engagement with people who are out of work because of health and disability. And someone said, what if we gave people a cup of tea when they came to the job centre? And someone else said, well, you can't do that because they might throw it on the work coach. Right? And I just think, if you're in a position where you can't give someone a cup of tea for fear that they're going to assault your staff, like it's game over. Like you can't build the sort of relationships you need. And on the flip side, I was doing a visit recently for a crisis team appointment, so going to visit someone who was suicidal, and she offered me a cup of tea when I came in, and I felt a bit rushed, and sometimes you feel it's like a bit of a boundary to cross somehow. So I said, oh no, I'm okay. And then she looked a bit like crestfallen that I'd said no to her offering me a cup of tea. So I said, oh, go on, give me a cup of tea. And the conversation completely changed. And like, it is those the little things mean a lot in these relationships, like the power dynamics and the quality of the relationship. But we completely fail to design for those things. We say, oh yeah, it'll be person-centered and trauma-informed, but what about the care pathway and how many points of contact you have? And we focus on all the wrong stuff. So I do think this idea of starting within this open access model, get the first conversation and that initial engagement right, and really design for quality of the engagement, that a lot will follow on from there.
Brilliant. I have loads of questions about service design, and particularly that your point, Tom, about really struggling to design services that matter. So I'm sure we could talk about that all day, but I will open it up to the floor because I'm sure there are plenty of questions. I'm probably going to take them in threes and then give them to panelists, and if we've got time for another round, I'll go there. I'll go to the front here, and then to the woman here, and then to the man in the interesting shirt there.
Thank you. Henry Anderson, Health Service Journal. I just wanted to ask about the response on the kind of NHS side of things, because I think a lot of what the government has talked about so far in terms of what it's doing has been, the crack teams in hospitals, getting elective waiting lists down, but then there is all this evidence actually a huge amount of the problem is down to mental health, and the share of spend is falling, etc. So I just wonder if you feel there's a bit of a disconnect there between the kind of what the evidence says and what the policy response has been.
Yep. And then here.
Hi, Jenny Edwards, Chair of People's Health Trust. Issue really close to our hearts because we have a pilot programme using the voluntary sector in communities that have the highest health inequalities to get young people with mental health problems into work. Don't have the outcomes yet, we're halfway through it, but we're really hopeful it's being evaluated by NIHR as well. I never thought I'd say this, but there is a model in the US where they've actually made this work over time in Philadelphia, where they took a public health approach because the mayors there have control over acute health spending as well as what was very little public health spending. What they did was over a series of years build relationships between the health services that are under incredible pressure and local community organisations, including churches and pastors and so on. And then all the initial contacts that the community had were with the organisations that they trusted, and their people there were trained, and they appropriately moved a much smaller number of people on to the right level within the professional services, and the great relationships developed. So please go and have a look at that. I think you might find it works.
Brilliant. Then the man over here. It's back here.
Hi, we were just looking at each other and trying to work out who has the interesting shirt. So my question is about trade-offs. So we heard that young people with mental health issues are a big reason, a big drain on economic activity. I'm a doctor by training, so every week at the other end of the age spectrum, I will maybe clerk someone most days who their only reason to be in hospital is that they can't really walk very well, but there's no other actual medical issue. And once a week, I might clerk somebody who's on a palliative trajectory and actually has a plan not to come into hospital, but nobody's brave enough to stick up for that plan. So my question is, do you accept that there's a trade-off between helping those young people get back into economic activity by helping their health problems, which is what the NHS, the original logic was for, and actually a very cost-ineffective model at the other end of the age spectrum that we could be doing a better job of?
Brilliant. I know that not everyone can hear all of the roving mic questions, so I will just repeat them. The first question is about a disconnect between essentially the priorities of the NHS around electives and performance and the evidence on what will make a difference to getting people back to work? Do we have the kind of balance there right, or is there a disconnect there? Second question, which is actually a comment, but I'm going to take as a question, which is about why is it such a struggle to get more relational approaches or different approaches to service delivery off the ground? Is that an issue about cultural aversion and risk? Is it about where power sits? What's the issue? And final question about trade-offs between what works for young people in economic activity and for older people. Is there a trade-off there? Do we accept that there's a trade-off, and how should we prioritise resources where trade-offs exist? I'm going to start with Sonia.
Is there a disconnect? Yes, there is definitely a disconnect of how we're funding community care and how we're funding primary care and how we're funding mental health over physical health. So the NHS was set up with an iron brain with mind of disease and to get disease under control. It wasn't for complex ageing populations and preventative work. The model needs to be completely flipped on its head, that we are doing all of that. We've got an ageing population, and longevity and good health throughout your whole entire age in terms of working age is absolutely essential, but it's not the priority as yet. So the first sort of, I think, seeds have been placed in to start doing that, because at the moment most of the funding goes to secondary care because we need to get people off waiting lists. So there's definitely a disconnect. In terms of the golden thread, is absolutely essential to make sure we have all the services lining up in a way that when someone needs care, they get it as soon as possible. And I think it comes back to me going, we need to be thinking about multi-agency hubs, and they should be on the high street, and they should be where people can access. They shouldn't be in a hospital which costs so much money to get onto, to park the car and then get out of the car and then walk 5 blocks across. If it's on the high street, you go in, you bring more footfall, economic footfall, because people are fasting for their bloods, go and get their bloods done, come out, go and get a piece of cake. Oh, not cake, shouldn't say that as a physiotherapist, piece of fruit. And then, you go home. So I think there needs to be a good model care there, and that includes the DWP, because I think when people are thinking about care, they're also thinking about access. And you're right when you say, Chris, we're talking about health, and definitely health has been given the biggest budget since 2010, excluding COVID, under this government. But we also need to be looking at education, business and trade, all the other elements that sit under it, like getting DSET involved so that people can be more innovative about how we're resourcing it. 42% of the budget, NHS budget, is going on, something like that, around that range, is going on just staffing. So much of the budget goes on staffing, and actually if we got more digitisation, using AI, being more productive and putting that money into actually services for frontline, I think this would then be redigged in a much better way. And then talking about trade-offs, and it's funny because someone said to me, oh Sonia, what do you think about getting rid of the triple lock? And actually we should be doing a triple lock for young people and going the other way around, because at the moment the boomers are having a much better quality of life, and we're going to have a generation that's going to be missing out on getting on the housing ladder, getting a good qualified job, and being able to actually have better life outcomes in all aspects of life, including work, less likely. So I think we should be doing some work. I think we're supposed to be training the new generation. We're looking at young people. Social care, health and social care, we're looking at hospitals in particular, I think needs to be a priority. I know 3 years is what we've said about the case review. I do think we should be reviewing at whether that should be done quicker, because unless we get people out of the beds, out of a hospital and going out to the community, and that includes local government, so that's that department as well that needs to be able to discharge patients out. We're not going to be able to, we're going to keep having people in hospital beds unnecessarily for days and days and days and not discharging them. So I think there's multiple agencies, and I think we come to a point where we're all agreeing there needs to be more connectivity between the departments, and also from a national and then local ICB level from a commissioning point of view, and as we draw it all the way down to actually community and grassroots organisations and the third sector.
Thanks. I suppose just to pick up on that point about staffing, I mean, to my perspective, there isn't a problem with a large proportion of the NHS budget going on staffing. It's what those staff are able to do, right? So if there's good technology rolled out with the workforce that can enable those staff to be even more productive and to do more work better, fabulous. A couple of points from me sort of on those broad questions. I mean, I think on the example of sort of community-led responses to young people. It's really interesting, and I think it is a really important part of this debate. I've been really struck by people who are making points about schools' role in all of this, and that when we extended the participation age way back maybe 10 years ago, there wasn't the same level of support put in place for young people who were 16 to 18 and now legally compelled to remain in education as we would want to be the case. We've also got these risk of need indicators, which schools have to collect, and there's lots of monitoring and collection of children all the way through. And then what happens at the end, at the moment, and I think the Milburn Review has pointed to this, there isn't a lot of accountability for, what happens with all of that information. So I feel like there has to be a solution, which is to give, whether it's schools or whether it's another local institution, some responsibility, whether it's the new youth hubs, for taking this information, for keeping hold of those young people, and then for pulling all the local services and everything in so that that connection is there, and then they're supported with whatever that local area knows best is going to work for them. That seems to me to make an awful lot of sense. On the trade-offs point, I'm never going to sit here and argue for trading off one group against another, but I think the facts show you that if you don't intervene to help more of the economically inactive young people today to stay in work, well, everyone's going to lose big style, because one of those kids who stays out of work for the rest of their working life is going to be £1 million better off themselves over the course of their lifetime. If they don't have any earnings, they're going to have cost the state a whole lot of money. They're not going to have paid any taxes, and it can't be afforded. And when you look at what's happening with sort of the number of NEET 23, 24-year-olds who've never had a job, it's higher than it's ever been. And if that population of young people aren't supported into work, and if that high level continues, there's going to be a higher cost because of the years and years and years in which those young people aren't able to contribute, and in turn aren't even able to build up a pension. So the sort of everyone loses if we don't help young people into work, and older people won't have the revenues that are needed to support the services they need. That would be my response on that one.
I guess the first and the third question about prioritisation, and Henry, my view is obviously yes. I think this government picked the wrong target for the NHS. It sort of drags money into acute hospitals and hampers its attempt to shift things to more preventative local care. I also think it was a political mistake in the sense of, you ask people what really bothers them about the health service. It's, I can't see a GP, probably number one. The queue in A&E was horrendous, probably number two. Number three is, my granny fell over and broke a hip. No one came for days, and now they did come, I can't actually get her out of hospital again. So I think addressing those issues would have been cheaper and probably more in line with the stated priorities of the government. In terms of old versus young, I guess mathematically, yes, if you're spending one on one, you can't spend it on the other. I think it would be a brave politician who phrased it in those terms, and probably not the most helpful political conception. But I guess the sort of policy point is, there was always a sort of hope that if we could say, well, actually, if we intervened earlier and spent money here, whether it's young people or whether it's older people, we would get better results and we'd save money further down the line. And the Treasury always yeah, right. And I think the key to any of this is where is there the evidence of that? In some cases, it probably will be true. In some cases, it sadly won't be. And working out where that is true, where there's good evidence, and there, it helps build an argument for say, well, we can at least prioritise this because we know it will pay off.
Yeah, just quickly, the bit I wanted to pick up was from the example actually of from Philadelphia, because I think there's a really interesting challenge here that there's an issue around the access point into services not being very good often and being too short and constrained, but there's also an issue around diversity of access points, and the third sector can be really good at that in terms of being a different place someone might go, but it needs to then have heft in terms of what are the referrals that are made on the back of that conversation, and can that direct people in. And I think the critical thing there is around marginalised groups. We know that there are lots of groups that don't access mental health support early, and particularly people from certain racialised communities that tend to present much later in the mental health system at a more acute stage. And the risk is that we end up responding to, the thing that will be kind of front and centre here at the moment is the Nottingham inquiry and Valdo Callicane, and the risk is there that you end up pulling the easy kind of lever, or the more coercive lever, which is let's just be more harsh at the acute end of the system in terms of the risk assessment we make about whether we section people, whereas actually the thing that would ultimately address those or reduce the likelihood of those incidents occurring would be more people being able to engage at an earlier stage But we have a mental health system where there are lots of groups who don't feel able to do that for a range of reasons. And I do think one of the answers to that is a kind of diversity of access points. And lots of our local mines deliver really great services where they have a kind of open access model where people can come in and have a conversation. The risk is, or the challenge is at the moment, that it's hard for that to properly dock into the system, and the NHS can be a bit of a closed shop on that front.
We might do another round of questions because there were plenty of hands up. We're going to go here and then here. Actually, maybe start with Mark here because it's closer.
Well, thank you very much. I think, you know, this, it picks up the question from the, interestingly, shirted gentleman, but to come down to the kind of ethical hub of the question, I'd be really interested on the panel's views on should the NHS be reprioritising money towards people with a good chance of going into work rather than clinical need or clinical potential to benefit? Because there's obviously arguments for that. I think we've heard a few of them. But that would be a really big shift in the way that the NHS allocates money, approves products, expects its clinicians to work.
Brilliant.
Hi, Tom Rhodes from FTI Consulting. My question is around the depth of the role of employers in providing health. There's been reference to musculoskeletal conditions, mental health conditions. If you're fortunate enough to work for a company that provides health insurance, you'll often find that you can access services the same day or the next day. So is there a role for employers to actually be a primary provider for those types of services to alleviate pressure on the NHS to actually deliver for those who don't have the same access to those services?
Brilliant. And then one more over here.
Hello, I'm Wahid Ahmed. I am a public health doctor based in Solihull. Now, we know that healthy employees are productive employees, so it's in employers' interests for employees to be healthy, and this aligns with the government's Get Britain Working white paper. So I was involved in leading a project at Jaguar Land Rover Solihull, which is the headquarters of JLR in the UK, and we included around 1,300 employees in this pilot, and the whole point was taking NHS health checks to the workplace setting. Now, we know that employees working at the production line are less likely to access healthcare, and the findings from this study were stark. We found over 10% of employees had hidden risk that put them at high risk of cardiovascular disease, so undiagnosed diabetics, hypertensives, etc. So my question is, what's your thoughts around getting behind this idea of workplace-based health checks? I personally feel that we can hit two birds with one stone. We can, because it's in employers' interests for employees to be healthy, and we can take prevention away from the NHS where we know resources are very limited to the workplace setting.
Brilliant. So just to repeat those questions, the first one was on ethical questions about resource allocation in the NHS. So how do we make ethical calls about where resource should go to the working age population or to the most need or to maximise population health? Where should we sit on those questions? Second question was about a deeper role for employers in this space and perhaps some harder incentives on employers or disincentives on providing services in-house to alleviate pressure. And final question is on health checks and potentially as an extension of that question, moving prevention out of the NHS's focus and moving it more directly into what employers do. So I suspect some links with that second question as well. Start with Sonia on that.
I'm going to talk about Solihull Guy because I'm a Midlands woman as well. So I'll start with you first, Wasim. I think that is absolutely key, is if we are doing all the preventative work if we prophylactically look after the population, we're less likely to then get them into more complex conditions, less likely them to get into a position where they're going to need secondary care operations. If you can manage your diabetes, your blood pressure in primary care, or the community that's even better, or your heart condition or cardiovascular, whatever it is that we have, then you're less likely then to go, right, you're going to have a heart attack and then going to need secondary care, and then the A&E input, the surgeon, all the aftercare that comes with it, and on very complex medication, because you know the first thing is staffing and medication is costing NHS a lot of money. I do think we shouldn't be letting go of staff. I can tell you that now. As a HP and as a physio, wouldn't suggest that, but just being more effective. So I think that's key. So what we've done as the government is looking at pharmacy first. So some of those preventative things, like a health MOT, happens straight away. So you're having to think about where as a GP is booking an appointment. You can go into the pharmacist on your high street and book your appointment. And they're now getting rolled out even more because, again, it comes back to prevention. I sound like Tony Blair, like education, but I always say in the chamber, prevention is absolutely key, because we pick these things up quicker, they're more likely, then it's not going to be so expensive to manage. So totally agree with also some groups, especially males, unlikely to want to speak about mental health. Certain ethnic minorities don't want to talk about that in particular. So looking at, and it comes back to my initial point of looking at like a health biosphere. If you know the demographics really well of the population you're serving, you know what their needs are. So if you know that this is a very deprived area that has less likely to access health, then you really should be bringing health into the high street, into a neighbourhood hub, which is what the shift is into the community, instead of saying, right, what we're going to do is put it in a hospital and people are quite worried and scared to go access it. So you've got to make it as easy as possible. In talking about and I kind of wrap that up in terms of the employers bit, I agree 100%. If you are a business that is making millions of pounds, it is so much more effective for you to have an occupational therapist or a physiotherapist or a social prescriber in-house that you can be referred to, because you're more likely to then have people stay in work, but even if they're doing reduced hours, but then they're no longer going to go off work. So if you are an employer, it's a win-win for you. And also it's buy-in, because if you know you're investing into your employees, the employee would therefore be investing into the business. So they think, well, you're looking after me, you reduce my hours, actually I'm doing a phased bit of work. It's a win-win. I know this is going to be challenging for the SMEs because it's a bigger, I wouldn't say burden, but it's obviously a higher cost for them. And that's why it comes back to actually having good services on the NHS and access firsthand, instead of having to do that for particularly the SMEs. Ethically, I totally disagree, I'm really sorry, but I am a physiotherapist by background. I did an oath that no matter what your problem is, no matter where you come from, whether you economically benefit, you should be providing care free at the point of access, and we shouldn't be thinking about pitching one person over another if you're not going to be economically active, and therefore be more likely to take resources as you age. That's the benefit of being in the NHS. We've got advancing medication, people are surviving more long-term conditions, they're surviving even though, if you've had a, premature birth. It's fantastic. We should be celebrating this, and I think we're talking about things that are not going well. But in terms of life expectancy in the UK, we're doing really well. In terms of getting access to a GP, yes, it takes a long time, but we're now making it easier to have an online system so you can access it. So I think we should be downbeat about some of the greatest institution in the NHS, and I think it's a treasure to be, going, it's too much, it's taking too much resource. It's a fantastic opportunity, but it just needs to now be future-proof for the modern age of where we are right now.
Well, thank you. I think on the in-house occupational health, there are many employers that are doing this, and when the Health Foundation was doing their work earlier this year, they spoke to several of them, and I remember the co-op was one of them, and some of the reasons that they gave for providing this was that they were just having staff who had such long wait times on the NHS, and it was much quicker and easier for them to be providing and investing in support themselves and to address medical need of their colleagues earlier. Not all employers can or will do it, and I guess that's where we got to with the Mayfield review, because then the crux of it is someone has to pay for it, and if the NHS isn't going to pay for it and it's not going to be paid through general taxation, well, who is? But I think it's a good idea in principle. The challenge, I think, is that what isn't maybe talked about enough is that when we are talking about a population of people who are economically inactive on out-of-work support and with ill health, they're often people who are moving into minimum wage, entry-level jobs, or have cycled from low-paid, insecure, fairly poor quality jobs. And that's not the same population very often as the population of people who are working in professional roles where they've got occupational health insurance and they've got free medical checks. So there is sometimes, I think, in this debate, a real disconnect between, not that people here are doing it, but between the sort of services that are best in class that get discussed and the realities of the working lives of the people who need that sort of support. And that, to come back to it, is why I think some of the real basics, like the Employment Rights Act, which has been a huge benefit that the government has introduced for people at work, really matters, because, you know, at the moment now, if you're sick from work and you're on a low pay and you're in one of these roles, well, you'll get sick pay from day one. We know that sick pay from day one means people don't go into work when they're sick. We know that it means people don't go in and spread illness around. We know it means they recover more quickly. And we know that when you've got sick pay and some income replacement, you're more likely to stay connected to the jobs market. That is a small change, but it's a transformative change for like 8 million people who didn't previously qualify, many low-paid women. So I think it's also getting those very basics in terms of the floor of employment protection, right, that matters in this space, as well as the sort of bigger, cross-organisational, high-quality occupational health schemes, which some employers are just nowhere near to at the moment.
I mean, I guess on Mark's point, I mean, I think governments that have tried this have met a pretty unified reaction that this is not what people want, it's not what they think the NHS is for, and it is, either morally or politically repugnant to them. But even if you say that is the case for the NHS budget, the government spends a lot of other money on similar things, and there have been discussions in government about how you can shift some of that resource into extra support for those for working age. Whether that's saying, well, why are we paying, this money we're paying benefits, could it be better off spent on the kind of employment support or mental health support, whether you do that through voluntary choice or other mechanisms. NICE has been looking at that, DWP has been looking at that, and it is obviously difficult. You've got how you do it, you've got the AME to DEL split, but it's probably think about what else the government spends and how can we prioritise that on people of working age that is probably more fruitful. And then on the point about employers, I mean, yes, in some cases it is in employers' interests to get people back to work, but it won't always be. It depends on, well, how much has this loss of productivity cost and how much will it cost to fix it? And if the second one is higher, then they're going to say, well, actually it isn't in my interest. So it's the job of public policy to sort of lower the cost of making it better, I guess, or perhaps raise the cost of not making it better through other kinds of incentives. And I think what Mayfield is trying to do is show a system that works for the first group where it is in their interest. He's trying to essentially create an employer-funded national occupational health service. So he wants to show that works with employers who do think it is in their interest but find it a bit difficult and don't have the economies of scale in terms of buying that support. And then once that's up and running, hopefully show that as proof of concept to say, well, the rest of you, we're now going to have to use sticks and carrots to ensure other employers buy in.
So I agree with Chris about the idea that you could look to increase the level of support around mental health provided to certain groups without making that a kind of point of clinical access decision about does one person get it or not. So I think that it could never be the case that when someone goes to seek medical support, let's say from a GP, that decision is made on the basis of, well, you're young and unemployed, so this is a better bet for us to make. But I think there's a separate conversation about can you beef up the quality of mental health support, or just like the mental health skills of staff who are working in a space like employment support. The bit of that I worry about, and we've heard a lot of this in some of the government rhetoric around this, is this idea that somehow there is like a simple trade-off to be made between giving someone benefits and, we could spend that money better on this thing instead. And I worry a lot about a debate that intuitively thinks that the more benefits someone has, that necessarily means they're less likely to go back to work. I think a lot of us in this room will have benefited from having a degree of financial security, and we would have felt that as an enabler rather than a hindrance to doing stuff. And yet in this space, we always assume it's a hindrance. And I think there is a very real trade-off that if you took money away from people, that makes their day-to-day life materially harder, and we know that has a material impact on mental health. And of course, there is the debate about levels to be had, but I do worry about sometimes the government has framed this a little bit as a simplistic trade-off between one or the other.
Brilliant. We are just about out of time on this panel, so I will give people opportunity to say any closing remarks. And maybe the question here is on the debate about work and health, what maybe from your constituents, Sonia, or people that you talk to in the trades union movement and employers, Nicola, and in Whitehall, and perhaps in service design and mental health charities, what are we missing from this debate? What's the area that we're not talking about enough that springs to mind but is absent from the policy conversation nationally?
I think I've already set out my stall that I don't think we've got too many fragmented silo services that could be joined up, and the data that we have currently on the population, if we merged it into understanding population need, we will build services for patients instead of what we're doing is building on what we think it is. Now, some places are doing something, but not to the extent that I think we should be doing, looking at green spaces, looking at poverty levels, looking at levels of high street takeaways. And it's not just near schools, but looking at across the borough, what is needed, and then incentivising businesses, to do healthy food, incentivising, we need more green spaces, so that's local government. Okay, we need there's not enough good paid jobs here, so actually people are going into really poor paid jobs, like in my constituency, and then not adding to then hitting a glass ceiling. Okay, so maybe we need more techs, that's decent. So all the departments are responsible for this, and I think there is fragmented care across the board, but there is some knitting together, as many departments are working on this. But I think that needs to then be not just at a national level, it needs to be then at a local mayoral level, then at a local sort of council level, so every single person's on the same pitch, so that when we're building services, so if a place needs somewhere that needs a multi-agency help with DWP, with a college talking about getting people into needs, and then health and then mental health, and we've got a story building all next to each other, and then brings into the economy, because we need that will also help being footfall. I think that's absolutely essential. So I think there needs to be looking at population need, and from a constituency point of view, that's exactly what my constituents are saying to me. They're saying, Sonia, as I did a massive roundtable with, I think, over 30 people, all from my biggest organisations, they are repeating the same thing to me. So it's what I'm hoping to put out to government, who hopefully it will be James Murray, but if it's not James Murray, someone else on the pitch on this, as I've rolling the pitch out into many places. But yeah, that's what I think needs to be going forward. And so thank you so much for inviting me on this panel. I think it's been really great listening to people and their views, and it's been a really brilliant conversation on a very warm day.
Thank you, Nicola.
There's an enormous amount going on across government on job quality, on industrial strategy, on jobs plans from industrial strategy, so on both job creation and on job quality. I guess I wouldn't say anything, I wouldn't say there's actually a large amount missing. I think what I would like to see is a really consistent cross-government recognition that both the number of jobs and their quality matters hugely to very many policy metrics, and labour market policy across government should consistently, whether that's across Treasury, whether that's across DBT, whether that's DWP, be pushing in both directions at the one time. So I think what I would really like to see is a really clear, explicit cross-government commitment that more jobs and better jobs both matter, and that metrics that reinforce both of those core requirements are going to be consistent across departments.
Well, obviously it's tempting to say the missing thing is, what does Andy Burnham actually plan to do about any of this, which is obviously the only question in Whitehall at the moment. But I think probably a better answer goes back to Tom's nice anecdote about whether you offer someone a cup of tea, which is the actual voices of people for whom these services are not really working. We've all been along to pilots and schemes that are working well, and you speak to people for whom they are working, but there are a lot more people for whom they are not, and it is, we don't really understand why. It's quite hard to go at, it's quite hard to generalise from that, because there'll be many, many different reasons which don't fit neatly onto a sort of policy scoreboard. But until we really understand why it isn't working for people, it's quite hard to fix, I think.
Yeah, I think I broadly agree with that. I would say the one thing would be to shift more resource and effort into giving more people access to a really good conversation about why they're struggling and what they need as soon as possible, and start getting serious about thinking about how do you design for that to be a really high quality interaction that leads to the right support rather than getting stuck thinking about what's the process and what are the touch points.
Brilliant. We are out of time, so I want to say a huge thank you to all of our panelists. What's been a really fascinating discussion. So if you can warmly thank our panel. Yeah, of course. Brilliant. We might make a start. Thank you all for persevering. We've got there to our final panel of the day, both metaphorically and physically. We're kind of on our final stage. We're extremely excited. We've been excited about all of our panels today, but particularly about this one. What we want to talk about in our final session today is about transforming health in older age, which is perhaps our most important demographic challenge in this country and affects everything that we do in health and care services and beyond. A little bit of framing here. We have an aging population, but the number of years that people can expect to live in good. So we have increased life expectancy, but the number of years that people can expect to live in good health has stalled. Life expectancy is now just above 80 years, but healthy life expectancy is only now 61 years. So there's a 2-decade gap between when people contract a major illness, when they start living not in good health, and their end of life. And we know that in more than 10% of local authorities in England, healthy life expectancy is less than 55 years old. So the questions that we want to focus on today is, how do we close that gap? What does that mean for health and care services? But perhaps more importantly, what does it mean for people who provide the vast majority of care in this country? People who self-manage their own health, carers, families, communities, neighbours and friends. How do we take a proper whole-of-society approach to making sure that people age better in good health? And with me to discuss that today, we have such a brilliant panel. People will notice, been some changes on this panel due to transport issues, but nonetheless, we've managed to find worthy replacements. Firstly, we have Katie Stiles. Katie is a full-time unpaid carer to her husband, Mark, and increasingly to her mother as well. She's a nationally recognised campaigner, and she's a founder of the We Care campaign. Secondly, we've got Dr. Alex Osborne. Alex is a policy manager at Alzheimer's Society, where she's worked for the last 5 years, and previous to that, she worked in Parliament. We've got Ben Collins. Ben is a program director for health and care integration at Hounslow Borough-based Partnership and West London NHS Trust. I hope I got that right. Ben's also an associate fellow at the King's Fund, amongst other things, and he used to work at the King's Fund as a projects director. And last but not least, we have Carol Easton. Carol is the Chief Executive of the Centre for Ageing Better, who've done wonderful work in this space about reframing what it means to live well in older age. She has extensive experience in the voluntary sector, and she served as an interim Chief Executive at Refuge and the British Lung Foundation. She began her career as a psychotherapist. That is our panel. No more from me. I'm going to pass over to Katie, and we're really keen to hear from Katie. A lot of the conversation we have around healthy aging gets dominated by conversations about how formal care services join up with one another, who should sit on the integrated care board, how the local authority should partner with the NHS. We're really keen to hear from Katie about what that feels like as someone navigating services in real time, what it means to provide care for someone day in and day out, and what a settlement would look like that made it easier to do your often much harder job than other people are doing.
Well, thank you very much for the invite. I'm very honoured to be here. As has already been mentioned, I'm a founder of a grassroots organisation called We Care, which amplifies the voices of unpaid carers to decision makers, but primarily I'm here because I'm an unpaid carer myself. I care for my husband Mark, who is living with a rare form of motor neuron disease, so I support him with his personal care, his appointments, all of the practical things that allow him to live a good life at home. And also I am caring for my mum, who's 88. She was in her own home. I'll talk a little bit about that in a minute. Supporting her meant organising all of her shopping, banking, laundry, organising the house to get cleaned, her hairdresser, dentist, chiropodist appointments, the window cleaner, all of her drugs and medical appointments, as well as keeping her connected to her community and friends. And I also support my husband to advocate and care for his mum, who has dementia, who is living in a care home now near to where we live. So just because he's got M&D doesn't mean to say that he isn't providing some sort of care for her. It's advocacy mainly. When we talk about healthy aging, independence and pressure on services, I think it's important
that we remember that much of that pressure has already been transferred onto families. And for those of us that they aren't policy discussions, they don't look abstract, and it's just our ordinary everyday lives. So in the last month alone, I found myself organising emergency respite for my mum to live in a residential care home, while standing in a hospital with my husband, trying to support his mum to be watered and fed, to drink, following a hip fracture. So I found myself coordinating different professionals, chasing up information, trying to ensure that through all of this, my husband wasn't being totally worn out by it all. And I'm not alone. Care is complex these days. I've spent hours on the phone this last month. I've made 60 calls, would you believe, in the last month, repeating the same information again and again and again. And I've had nights obviously worrying about symptoms for all the people that I care for, because obviously they don't follow office hours. They never happen at weekends, do they? Neither during a heat wave. So yeah, that's my life. And I can't really think about my own future and healthy life for me, because I'm trying to get through every day one at a time. I get through every day that is in front of me. And these things are rarely captured in policy papers. I think the biggest misconception is that pressure at different times disappears. It doesn't. You know, we talk about seasonal pressure, we talk about flu season, we talk about all sorts of different things within the system. But when services are stretched, pressure simply moves. And it moves into family homes, onto family relationships, and onto, I have to say, mostly women of a certain age. So if you're middle-aged and a woman, you're more than 50% chance of providing some care. These pressures have backdropped to my life, and life gets filled around caring. Caring isn't done around my life, if that makes sense. We talk about closing the gap between living longer and living well. And what does the system get wrong about supporting people to stay independent at home? We see independence as doing everything alone, don't we? But few of us actually live independently or in isolation. We all rely upon the people around us. So for older and more disabled people, staying at home successfully depends on relationships. Independence is made possible by interdependence. So my mum up to recently had 9 friends, family, and neighbours who were all doing different parts of her care, but that still wasn't enough to keep her out of a care home. The system tends to focus on crisis rather than prevention. You all know this. And support for carers, when it arrives, is when we are absolutely exhausted, unwell, in hospital ourselves, I have to say, or at breaking point, if you are lucky. Yet small interventions earlier on, a bit of respite here or there, a piece of equipment that helps or supports you, a chat with somebody who knows what's going on at home so you don't have to explain it all over again, really help. They help with sort of navigating the service compassionately, and you don't just get ended up with a website address, which is just another job for me to do, to be quite brutally frank, and that makes an important difference. Carers are often the only thing keeping somebody living in their own home, but we're treated as an afterthought. Supporting carers is not separate from supporting independence, it's the same conversation. And it's often said that we prop up health and care social systems, often invisibly. I've heard that today, but I think that's just very convenient. We're visible. You know, I could probably pick out every carer in the supermarket, working in a hospital, and that shouldn't be within the wit of anybody else not to be able to do that themselves. It's just we're not on anybody's financial spreadsheet, and I think that's where the invisibility lies. What would meaningful recognition and support mean to me? Well, it means identifying carers early. It means providing practical help before a crisis. recognising carers as service providers and partners within this system rather than just a free resource. And finally, I'll just wrap up by saying, you know, carers like me can't wait until the Casey Commission gives its report. We're exhausted now. And I know from the Health and Social Care Committee meeting that she had yesterday that she mentioned that breaks and sorting out replacement care would be one of the things that we could do quickly, and I would absolutely want to endorse that. Guaranteeing breaks for carers makes a huge difference. I'd also reform carers allowance. She said that she thought carers allowance was a good thing. I wouldn't go that far. It's outdated, restricted, and in this context, it doesn't support carers to support themselves, to be able to support somebody else. So that's really important. And finally, my last point is that we need to have carers and the people that we care for in the rooms like this. You know, I hopefully am not the only person with lived experience in this room, but more often than not, I am, and that should never be.
Thanks, Seb. Yeah, thanks very much for having me on the panel. So to give a bit of background on dementia, as Seb's already said, we've got an ageing population, and what that means is rising prevalence of dementia too. So nearly 1 million people living with dementia in the UK now, but that's rising to 1.4 million people by 2040. And what that also means is that the pressure that dementia exerts as a condition on the health and care system is rising, and that means rising costs too. So by 2040, you're looking at £90 billion cost caused by dementia to the economy. And, you know, there are lots of opportunities to improve people's experiences of dementia across the whole pathway. So, you know, if we're thinking about prevention, there was a great paper that came out from the Lancet Commission a couple of years ago that found that nearly 50% of cases of dementia are potentially modifiable or preventable. But many people, when we do public polling, don't realise that that's the case. And a lot of these sort of preventable factors are things throughout the life course, many things that we've heard today. So, you know, poor educational attainment in younger life is one factor, but things like smoking, drinking, hypertension, all playing a factor here. Also things like air pollution, so there's a big health inequalities angle here. But if people aren't aware that they're able to reduce their risk, then they're not going to be able to reduce their risk. So I think there's a public health messaging point that needs to be made there. When we think about diagnosis, 1/3 of people living with dementia in the UK don't have a diagnosis. And I think for many health conditions that would just not be accepted, but because dementia is a condition of older age, there's perhaps not the same prioritisation. And I think also because it's a sort of long-term progressive condition, there's again not the urgency that's needed to act on dementia. And in particular, what we see is that people aren't getting diagnosed early or accurately enough either. So nearly 25% of people that are diagnosed with dementia are just told that they have dementia. They're not told what type. And we also know we did a series of visits to memory assessment services over the last year to inform a report that we put out recently. Anecdotally speaking, these services are telling us that people are not presenting to the services early. So stigma is a big issue. People are afraid of being told that they have dementia. So there's definitely work, I think, within the sector that we can do to promote the benefits of diagnosis, and particularly early and accurate diagnosis, so that people know what help is available to them if they do get diagnosed, but particularly the benefits of early and accurate diagnosis specifically. So what that means really is being able to access existing pharmacological treatments for dementia. There is no cure, but there are treatments available now that can help with symptoms. There are also a vast array of treatments in clinical trials. Globally, we've got over 150 treatments for Alzheimer's disease in clinical trial, I think over 30 of which are at late stage. So there's this amazing pipeline of treatments, but particularly the disease-modifying treatments are only effective or most effective in the early stages of Alzheimer's disease. And so there's this growing onus to get that early diagnosis. And it has loads of benefits for both the individual and for the wider health and care sector, right? So for the person, it gives you the basic dignity of knowing what's wrong with you. It means you can plan for the future. It means that you can access existing treatments at a point where they're also more effective. But for the health and care system, it has massive benefits in terms of preventing avoidable hospital admissions. We know that I think nearly half of emergency hospital admissions for people living with dementia are because of really easily preventable things like UTIs and falls. But because people aren't getting that early diagnosis and the care that they need subsequently, you're getting these crisis points that could be avoided, really. So emphasis on the early and accurate diagnosis, definitely. When it comes to care, Katie has covered a lot of the points that I would have raised, but to kind of reiterate, you know, we need coordinated care for people and a much clearer sense of what care is going to be available for people once they get diagnosed. Need that experience to be more streamlined for everybody. There's huge variation in diagnosis, care and treatment for dementia, and by standardising the pathway, it means there's a better chance of people having a kind of unified experience, because at the moment you've got fragmented care, long waits for diagnosis, and those waiting times are rising, and poor outcomes. But by ensuring that people get that diagnosis, by ensuring that care is coordinated and also delivered by people that are trained in dementia, this is another big issue. So only 29% of the social care workforce in the UK have any training on dementia, even though among over 65s, it's by far the most prevalent condition for people that are drawing on social care. So you need to get that training in place. And then on treatments, like I said, there's this amazing pipeline of treatments, and there's also really promising developments in diagnostics too. So we're seeing things like a potential blood test for dementia, really exciting. But we risk a situation where people are not able to access both innovations in diagnostics, innovations in care, you know, sort of tech innovations, and most crucially, exciting new treatments, and associated with that, the potential to participate in clinical trials because they're not getting an early enough diagnosis. So there's absolutely loads that needs to happen there. What I would say is that right now we've got two really exciting opportunities in the Casey Commission and also in the Modern Service Framework for Frailty and Dementia that the government is working on right now to galvanise that potential and hope that we're seeing from developments in treatments and diagnostics, but we cannot miss our chance. This is crucial. You know, particularly I think in the care space there have been many, you know, sort of commissions, research pieces, proposals on cap on care costs, levies, investigations, and people need help now. But it's also about funding. You need to have that injection of funding to kind of make change happen. With the Modern Service Framework, all of the things that I've mentioned are important, but more important than anything is not just focusing on the status quo and the issues that I've mentioned, but also being really big and bold so that we're talking about targets on reducing the number of people that die with dementia, and also ensuring that if people have dementia, the period in which they're in the late stages of dementia is compressed, so kind of compression of morbidity with dementia too. So we want to see the MSF utilised to kind of use those big goals. And my message really is that we have these opportunities now. The MSF is a 10-year plan, so it has to be big and bold. And yeah, in order to make sure that we're making the most of that opportunity, the goals in it have to be bold too.
Brilliant. Must have been.
So Katie, you're not the only one with caring experience, but I suspect you do a much better job than me. So my mum is 89. She lives on her own since my father died. She's got the usual bundle of chronic conditions that come with being 89, and she's getting more and more socially isolated as she loses her mobility. So a year ago, the problem with my mum was she had a swollen leg. She went to the GP, and the GP said she needed to put on a compression sock, but she couldn't bend down. So the GP and the practice couldn't help with putting on the compression sock every day. They sent her to district nurses, but district nurses refused because she wasn't housebound yet. They'll help her only when she gets housebound. So then she went to A&E, and they sent her back to primary care. And then eventually she found her way into a frailty hub, where they did a memory test and told her she was losing her memory, but she didn't need to do much about that. Had a falls assessment where they told her she was a bit wobbly, but they couldn't help with the thing that mattered that day, which was the compression sock. So then a well-being worker came round, and that well-being worker agreed that the thing that really mattered was getting this compression sock on. But that wasn't the wellbeing worker's job. She offered to install a handrail. So those are, I think, the Kafkaesque consequences of the service structures that we have developed for many groups of the population in England over decades. In my current job in Hounslow, I try and think about how we create a coherent model of care for people with frailty and others with complex needs. And we have 60 sub-service lines for frailty just in one organisation, West London Trust, before you start counting the council, the voluntary sector and hospital outpatients. So, if I think about what matters for my mum, what my mum wants, she doesn't really want, I think, necessarily the most up-to-date falls assessment or memory assessment or, access to specialists in the Royal Brompton for a rheumatology or whatever. Fundamentally, what my mum wants is to have a relationship with just one or two people in this very, very expensive welfare state that take this massive chunk of our taxes. One of the two people who know my mum and have got some responsibility for her. But instead, over 20 years of supporting two parents, now one, with frailty, 20 years of ups and downs and, an infection, a fall, a hospital stay. Every single time, one group of people gets involved before the hospital stay to try and avoid them going into hospital. Another group of people get involved to try and get mum out of hospital. Another group of people get involved to try and stabilise mum once she's back at home. Then they forget about her entirely for the next 6 months until the next crisis. And then a whole new group of people get involved. And I can honestly swear I've never spoken to the same person twice, not once. So for me, that suggests really, really fundamental, radical transformation of our system. We've got to smash up what we created without thought or strategy or coherent design over many decades and replace it with something completely different. So not the incremental improvement that I heard from Jim Mackey this morning, but radical transformation that comes from an understanding that what we've got right now is really, really unacceptable.
Thank you. I'm finding it difficult to hear, even the people who are sitting very near me, so please holler if you can't, because I think we're all having to speak incredibly clearly and slowly for you to be able to hear, so apologies if you can't. I was really pleased to hear you talk about something more radical. I think if Hilary Cottam had been here, she would have been pleased too, so thank you for that. I'm going to ask the question in a slightly different way, which is, what would it take to make Britain a great country in which to grow old? And how would we know if we're getting there? For the Centre of Ageing Better, which is where I work, success isn't about people living longer than anywhere else. It means that people in every community, rich or poor, can spend their lives in good health, with financial security, with strong social connections, and with dignity. At present, I'm really sad to say we're a long way from that goal. Over the past decade, healthy life expectancy hasn't improved, it's fallen. And the gap between rich and poor has widened. I found it profoundly shocking that there is a 20-year difference in healthy life expectancy between the most and the least deprived communities in our country. Closing that gap must be a test of our success. It's how we'll know if Britain is becoming a great place in which to grow old. The gap isn't driven by healthcare alone. We've talked a lot about health here today, but it's driven by the accumulation of disadvantage over a lifetime. Poor housing, insecure work, low income, limited opportunities. Poverty sits at the heart of it. If we're serious about closing this gap in the next decade, we must act decisively. National and local government must fix dangerous homes. They are making people ill. Reduce unemployment and poor quality, low-paid work. Strengthen public health capacity and prioritise place-based interventions in the poorest communities. These issues are complex and interconnected, and that means piecemeal action won't work. Individual interventions, admirable though they may be, won't be enough. We need a long-term, coordinated strategy for a changing demographic. Our society is changing. We are aging, but it affects everybody. And we need sustained political will to deliver it across government departments and successive administrations. I'm sure I don't need to tell you that political instability over the past decade has pushed these challenges aside. Despite knowing for years that our population is aging, we are failing to prepare. I believe that part of the problem is ageism. Aging still treated like a niche issue, as something that only affects older people. It affects all of us at every stage of life. And we need to change that. We need a national conversation that reframes aging as a whole society issue, that's shaped by and will shape experiences at every stage of life. We also need to link it to the government's domestic agenda. It's central to fairness, devolution, and economic growth. I don't pretend to have all the answers. Our focus at the Centre is on how we can make a difference to people in their 50s and 60s and beyond. But we know inequalities start much earlier, often even before birth. And if we're serious about change, we must act across the life course. So that means now to improve outcomes for future generations, but also acting now to improve the world for those already approaching life and for those carers. We're launching a project at the Centre looking at how we can make Britain the greatest place, well, maybe not the greatest, but a great place at least in which to grow old. It's going to focus on ambitious shifts across 3 policy areas: prevention and health, very pertinent to what we've been talking about here, work and financial security, and homes and communities. We want ideas from around the country, across and outside the ageing sector. And we know we need to build a broad coalition if we're going to create the momentum that we need and to influence government and successive governments to do what we think they need to do. So let's treat this together as a shared long-term priority, because if we get it right, we do have the opportunity to improve the experience for everyone who's aging.
Brilliant. So much in all of those opening remarks. I'm not quite sure where to start. I'm gonna take 5 minutes of chair questions, and then I will pass over to the audience. My first question is about genuine engagement, and it's maybe directed to you, Katie, but I'm sure others will have thoughts on it. But genuine engagement with people who use care services, genuine engagement with older people, people living with chronic conditions. I used to work in the patient engagement space, and it was always interesting that if you looked at reports of providers who did particularly badly on safety, quality, outcomes, you would always look at them and you'd look on their website and they'd have wonderful sets of carers participation groups and all the patients that we speak to and the ways in which we involve lived experience. And I was always kind of struck by that disconnect, and I'm really interested in your perspective of when this happens well, when it's done well, what does it look like to be meaningfully involved in a conversation with the NHS or with a care provider or with a public service or anyone else for that matter?
It starts at the very, very beginning of the conversation. You know, this isn't rocket science, is it? It starts at the very, very beginning. You're not slotted into the middle when they've made the decision that they want, and then you're just reiterating it back. So meaningful co-production, it's really meaningful co-design, to be honest, isn't it? Where you are enabled to be able to be in rooms. I mean, lots and lots of organisations forget that to actually get physically into this room, you know, you have to organise your life back at home. I know that's the same for parents and all of that sort of thing. But it's often forgotten about with carers. You know, you have to have somebody popping in to see my husband. I've had to ring the care home, you know, twice already today in that way. I've had to find, so far, you know, the money to get up here. That's a conversation that you need to have, whether you organise to pay for somebody's train fare or whatever it is.
And then if you're really serious about it, there should be some sort of remuneration for the people that are providing that expertise, because they are going to be the only people not being paid to be there. And that always, as at We Care and lots of other charities and organisations now, you know, we think about how we value what people have to say, and that's one way of doing it. There's you know, whether that's a voucher or a small amount of cash, it doesn't really matter the amount, but it's just a way of saying, this, we value what you are bringing to this conversation. And that rarely happens. Really, really rarely.
Alex, from a perspective of the Alzheimer's Society, I'm really interested in kind of engagement with people living with Alzheimer's and dementia, how you can really involve carers and also people living with the condition in their care.
Yeah, really good question. So echo much of what Katie has said already. I think another thing I'd emphasise is being really clear with the person about what you're doing with the engagement. So we have a whole team in Alzheimer's Society that is there specifically to engage with people living with dementia and their carers. And they've got a really neat framework that sort of says, you know, are you consulting? Are you co-producing? Are you just talking and scoping? Like, and as long as you're clear with people from the start, most people will be really happy to do really whatever you ask, but you have to set those expectations first. I think the other thing I'd say is sort of letting the expert organisations and then their networks lead. So something that's worked really well for us recently, both associated with the Modern Service Framework and the Casey Commission, is sort of saying to civil servants or, you know, staffers, like, we would like to run an event, we would like to invite this many people living with dementia and their carers, we want to dictate how that's run so that it meets the people that are attending's needs, and then facilitating in a really accessible way. So one of the reasons that we've had such great success with Baroness Casey saying what she has about dementia, she made some great interventions in Parliament yesterday talking about how it's neglected in policy terms, is specifically because she met some people living with dementia. I know they really appreciated the opportunity to engage with her directly. And I think the final thing is just trying to avoid, wherever possible, asking people to repeat their stories again and again. I know the Shadow Secretary of State referred to this as well. It's like if you're doing multiple consultations and multiple pieces of engagement, people will get frustrated if you're asking them to keep commenting on the same issues but in a different framework, right? So I think giving the opportunity where possible to share work that we've done previously as well, so that people aren't having to make the effort to go and do something that they feel they've done before.
Ben, do you want to jump in on that, Ben?
So we have a lovely, I don't think our work in Hounslow necessarily exhibits brilliant patient engagement, but we have this one person, Roger, who's in a wheelchair, requires oxygen, and he has sat in every design workshop that we've had over the course of a year to shape a new model of care for people with frailty, and he's been instrumental in bringing the practical patient's perspective on things like whether or not it's really feasible for him to be attending the 6 different outpatient appointments that he's currently expected across London to attend. And he's really helped, I think, to face down some professional opposition to radical change. And we do pay him, although there was a battle because the commissioners were very strict that they had a policy of not paying carers. All of that falls, I think, quite far short of, you know, if Hilary Cotton were here, you know, a really radical bottom-up approach to working with patients and the public to co-produce solutions, but something.
Carol?
I would agree with Katie, and I'm not going to kind of reiterate good principles of engagement of people with personal lived experience. What I would say is we learned a lesson at the Centre for Ageing Better, which was about who are we not engaging. And we were particularly concerned about marginalised, disadvantaged groups. And a couple of my members of my team went out and they contacted a couple of organisations, and they came back looking rather shamefaced and said, well, we got rather a bad response. And what we learned from that is that we went in with our agenda, not with the agenda of that group, and also expecting something from them rather than that this was an exploration and genuine, both financial but time and respect for what they wanted and how we could work together to hear from the people that they were working with and representing, so that it wasn't us defining the problem. Now, obviously, we have a bit of a stake and skin in the game, but that was a real learning for us, and it takes time. It takes real time and real commitment and real money, is what I would say. But if we're really serious about addressing inequalities, then we've got to do this.
I'm going to ask one more question. I think it may be the hot weather, but I'm getting slightly philosophical, and it comes from one of Ben's reflections before about what the system actually looks like if you're in it, which is lots of different encounters, bits of activity, episodes of care. It does seem like one of the problems that we've got into is that the relentless pursuit of additional activity and doing more and more, particularly in healthcare systems, has squeezed out our ability to care. So the currency of health systems is not care, it's doing more healthcare. And I think there's a difference between those two things. Is that kind of, is that something that chimes with people's experience? Do we need to have a different conversation about what it means to care and what care looks like as opposed to what optimizing healthcare looks like?
Yeah, I think I've laid out what care looks like for me. I think, particularly within the NHS, they are great at certain things. My mother-in-law with the broken hip, they managed to put her back together. Surgically, it was fantastic. But then we didn't have the care that I would have thought was pretty basic, which was engaging with her when she wasn't eating or drinking, why that was, the fact that she'd got dementia shouldn't have really made any difference. But there wasn't any understanding that if we didn't provide somebody to support her, then the easiest option was to put her back on a drip. And that's got to cost more. That's got to keep her in hospital longer. That's not a good outcome for her, for us. So I think that's what I'd say. The NHS has a responsibility to care for the patients as well. And I'm not outing any particular hospital. They were doing really well, but that just wasn't there.
And I suspect a lot of the hospitals will say, but all the bits of the pathway we got right, and we could tick the box that said we did X when we needed to, but that fundamental question about what we want out of care often doesn't get answered. Alex?
Yeah, I think for me it's about really good integration as well, because I think one of the big issues that people living with dementia face is that you end up falling through the cracks in the system, because you might approach your GP initially because you're worried about your memory, then you might go to a secondary care memory assessment service, or you might get diagnosed in a hospital, and then the care that you access, there's domiciliary care, there's care homes, there's like loads of different things that people can access. And sometimes dementia sits in mental health, sometimes it sits in health, sometimes it sits in care. And what that means is that people have to keep repeating themselves. They're not necessarily talking to people that know them and know their own experiences. I think there's probably still some issues about stereotyping around dementia as well. And yeah, all of that means, like I said earlier, that it's just a really fragmented pathway for people. And so for me, creating much better integration between health and care is key. I think being able to really tailor care to the person, because people with dementia, there are so many different types. We sometimes say when you meet one person with dementia, you've met one person with dementia, because their needs might be very, very different. So it's about making sure that people caring for them are trained in dementia, like I said earlier, and understand, how people might respond to different treatments and interventions, and then building care around that really. And I think we talked a bit already about being radical. Well, when it comes to care reform in particular, there's been so many conversations, but you have to reach a point where you just invest in care.
So I do think that we've lost sight somehow of what matters in healthcare over a few decades, seeing it as a sort of set of transactions and processes and services as opposed to something more humane. So in Hounslow, the test teams that I oversee in Hounslow, they look at the top 3.5% of the pyramid in terms of sort of people's needs and complexity. And just within community services, people in the top of the pyramid have had 18 separate referrals to different community services, and they've had 155 different interactions with those services. but they have no relationship with anybody in those services and nobody knows them. And I think that is a fundamental problem to fix. Relationship, continuity, trust, understanding.
I would agree about the relationship, but I wonder if this is connected to the fact that we don't value care. We don't pay carers, we don't pay child carers, we don't pay adult carers. We don't value them, we don't train them, we don't support them. They haven't got the time to build relationships either. And I think in your IPPR report, you wrote a lot about this, that actually that would contribute to GDP. We're really frightened in this country of taking these big steps and saying, oh, we'll build another train or we'll build another road, but what we won't do is invest in childcare. We won't do is invest in training and support for adult carers. And I think until that shifts, shifting some of the kind of systemic, errors or problems and barriers that there are in the system isn't going to happen. And I worry about, we've got 2 years till Casey reports. But is the world going to shift enough for her to have impact? Remains to be seen.
So right after this, I'm off to Singapore, where I'm going to really focus on how they do better strategic planning for health. But it strikes me, a lot of the barriers that you've identified are because we think we need substantial new resource.
We need
substantial new resource, a lot of new money.
Yeah.
The truth of the matter, Hounslow, we spend 200 million on the top 5%, 50 million of that is waste. There's enough resource and staff in the system to offer a really good standard of care if we could configure it right.
I'm going to open up to questions from the floor. Do we have a roaming mic? So the first question is here. Actually, maybe we start at the back and then move forward. We'll do it in threes again.
Hello there, Fraser Gilmore from Care Opinion. I kind of want to return to what you were talking about, Seb, around patient engagement. You knowing me, that's not surprising. We heard from Jim this morning that he talked a lot about how do we listen to the population and respond appropriately. And it's very welcome that we've got the new patient experience director that's going to be coming on board in England as well. But we have got a lot of challenges in the 10-year plan. And I do worry that there might be something quite reductionary about how we are listening to the voices of patients and carers. There's a lot in the 10-year plan around PROMs and around PREMs. But narrative feedback is what we've been discussing, really listening to what people have to say and how services are impacting on them and how they can then influence policy. And I think some of that does get lost in the 10-year plan. And I kind of wanted to flip the conversation that you were having on the head, is and ask you all, what do you think that risks if we're not really listening to the people who are using these services and the carers that are using these services? What do we risk if we're not hearing those narrative voices?
Brilliant. And then the man in the striped shirt down here.
Thanks. Hi, I'm Alistair Anderson. I'm a GP based up in the northeast of England, and I'm here with the Healthcare Leadership Academy. We've had some really interesting, thoughtful discussions. There's been some interesting themes around humanising and around systems, navigating systems, but also investment and values. So I was wondering, and there won't be just one answer perhaps, but actually, if you were to start somewhere, where would you start? So what would each of you start on over the next 3 to 5 years as a priority, personally, based on your own kind of experiences and backgrounds?
One more question here. Just here.
It kind of relates to that question. I'm Sophie from the Joseph Rowntree Foundation. A lot of you have spoken about a more radical, ambitious approach to social care and really changing a lot of the systems and needing to completely reinvent the wheel. Given that Burnham is pretty rhetorically strong on care, I'm wondering about if you guys, what your vision for a radical transformation in care would be, and kind of linking to the former question, maybe what the immediate priority would be for you if you could change it on a big dream scale.
Brilliant. Just so if anyone didn't catch those questions, the first question is about patient engagement or engagement with people who use care services or provide care. What do we lose and what's at risk if we don't listen to the people providing care and people using services or people receiving care? Second question is where to start. Priorities, if we could set some real priorities in this space, what would we need to do before the KC Commission reports? What's the 3 to 5 year plan here? And the final thing, which is quite a big question, but what is your vision for a radical transformation of care? And perhaps to keep it more constrained, what would be the one big thing? What would be the big priority? So I suppose those questions are in a way linked. I might start with you, Katie.
What would we lose? We'll commission things that don't support people, that are expensive, that don't actually work. Whereas if we'd listened to those voices, we could probably have come up with a separate solution that might not have been as expensive. You know, I'll be realistic. It's probably all down to finances, and so, you know, it makes good sense to do that. Second question was what my priority would be, wasn't it? I would like NHS England to have a duty of care on carers. Why we don't identify carers as soon as they walk through a GP surgery or through your reception desk or in hospital in an acute setting, I do not know, because it is fairly obvious. You know, the question is, who helped you to get here today? And then that is the conversation that you can have. And the third thing, my vision, crikey, crikey. I would just like to, my vision would be that we have some sort of social contract with carers, that we know what we are expected to do, what is more than we are expected to do, and what we should never have to do. I think those 3 questions would solve quite a lot.
Yeah, in terms of what we risk, ultimately, it's a system that doesn't work for the people that are drawing on it, right? You know, like I said earlier, 70% or more of people over 65 that are drawing on social care have dementia, and that means that you have to consider dementia when you're developing, you know, any framework, really. And I do think it still ends up getting forgotten or left behind, or, you know, not similarly prioritised compared to some conditions, and that includes engagement with people with lived experience. In terms of something to do now, I think it's about really pushing care upstream and getting away from this really reactively driven system. So for me, that looks like addressing what I said about early inaccurate diagnosis. You know, right now there's the 18-week referral to treatment elective care target, but dementia doesn't fall under that in most cases because of the nature of dementia services and how people get diagnosed. It does in a small number of cases, but mostly not. And in the meantime, you've got a 6-week waiting time target for dementia diagnosis that is never met. Basically, like 10% of services manage to meet that. So I think if we had an 18-week target from referral to diagnosis for dementia, and that should include care plan initiation and starting on treatment if it's appropriate for the person, that would make quite a big difference, and then that helps in terms of reducing emergency hospital admission, pushing back when someone needs to go into care, etc. So that would be the first thing. In terms of vision, so for the modern service framework, and I've alluded to this already, what we've been saying is effectively, no matter who you are or where you live, your chances of dying with dementia are reduced, and that you live better with the condition for longer, with that, like I said earlier, with that sort of severe stage pushed right to the end of your time with dementia, basically. And again, I think that's really about, in terms of how you do that, it's about standardising the pathway, making it really clear to people what their rights are, what they can expect in terms of their diagnosis, their treatment and their care, and ensuring that that's consistently delivered.
So I think it's a very good challenge for all of the conversation we've had today. We've got to focus, we've got to decide where will we place the investment and what are the big transformations we've really got to focus on. For frail older people, people with complexity, people living in really disadvantaged communities, the most important part of the health system is primary care. We need a good model of holistic, team-based, integrated primary and community care. And there's not a place in the world that has solved these problems without building that first. So neighbourhood health, if it's done well, could solve a lot of our problems.
I decided last weekend to take advantage of my local cinema where there's air conditioning, and gave up 2 hours of my precious life to watch Disclosure Day. I only mention it in case you haven't seen it because the word listen is very pertinent in that movie. I don't know whether that's a recommendation or not a recommendation. The disaster if you don't listen was very clear in that. So I leave you with that suspensing story. I don't mean to promote Steven Spielberg, but there you go. My priority as we wait for more reports to come and eminent people doing work would be that the current government commits to establishing a mechanism in central government like the missions that we started out hearing about when Labour first got in, and that this one would be about the changing demographics, and that we have mechanisms across government departments with targets and monitoring and all the mechanisms that these other missions had. And of course, preventive health and social care would be absolutely integral to those, because we're not going to sort it in a short period of time. We're not going to sort it in the life of this government. So we need something in place that means there is a longer-term view and a commitment, a binding commitment, so that one government after another takes it up. And we need to include things that we've mentioned less here today, like housing. Millions, 7.5 million people live in this country in houses that make them ill. What do they need then? They need social care. They need NHS care. It's kind of ludicrous when you look at it in that way. So housing, employment, they all need to be joined up in this initiative. We need to really put our hearts and our money and our voice into prevention so that public health gets a much bigger priority that is the case now. And finally, let's not pit one generation against another. You know, young people get older. What's good for young people today, they will be older. If we don't sort out what's happening to older people, to carers now, younger people will just have that to look forward to.
Time for another round of questions, I think. Or are we already out of time? We've got one question over here.
I only ask because nobody else raised their hand now. My name is Alexis Bradshaw. I have a background in system redesign from primary care. So my question is a bit radical. I haven't heard the word AI mentioned yet today. And I'm just wondering from all of you today, if you've seen any green shoots of hope from a technological perspective in your experience as a carer or in the organizations you're from, like that could properly help support the transformation so that people can do the relationship building and the work that only people can do in caring.
Do we have one more question and then we'll... Question. Over here.
Hi, Chloe from Carers Trust. My question is, for the carers and the people that you support, what do you think is going to be the greatest cost of inaction if we don't take those steps to improve things in care?
We've got one final question over here.
My question is about funding, and there's been some talk of radical solutions. Just wondering whether you think we need a radical solution to funding social care, potentially through things like pension funds, which have been muted around funding other investments. Should we see social care as more of a long-term investment that could be funded differently?
Brilliant. So again, for those who didn't hear, a question about AI and digital. Are there things that look exciting, different, that might change our ability to care? What are people's verdict on that? Second question is on funding and whether there is a approach to... I actually missed a question. There was a question from Carers Trust, which... No, I've not. Sorry, could you just repeat? Sorry, on the cost of inaction. There we are. Cost of inaction. And then the third question is on funding. Are there radical alternatives in the funding space? Are there ways in which we could fund this differently?
Do you want me to start? I can't really think of anything AIE. Digital, I'll just talk about the fact that a lot of people are digitally excluded, including carers. I think that's, my mum is digitally excluded, which makes it doubly hard for me then to sort that out, because I already have like an app that sorts this out, and you can't have two apps because, you know, you're already plugged into the one app, and I can't then create another one because that looks like some sort of fraud in the system. So there's that. The inaction for carers, I think it just means that there'll be an awful lot of people requiring an awful lot of health interventions later on. Inaction also means, and we haven't touched on this at all, that there are, particularly with, there's been some research about parent carers who are, have got a suicidal ideation. It's 41%, which is higher than, you know, people that have been, have got PTSD from military campaigns. So, I mean, that's the real inaction of not doing anything. And then radical funding. Yeah, I'd look at absolutely everything. I'll be really radical and say we've got to look at absolutely everything and then make a decision. So whether it's that is insurance policies, whether that's, you know, how much can it be expected to pay for your care, whatever.
Thanks. Yeah, on AI, there is loads of interesting stuff happening in the dementia space on AI. There's the potential for AI to be used to read brain scans is one thing. There's a lot happening at the moment around ambient tech and AI, so kind of ambient tech in the home that could detect when someone uses the bathroom or opens their fridge. There's even stuff like sort of sensory mats that detect changes in movement in sleep that can indicate if someone might have a UTI. So lots of interesting stuff happening. There's also, we've worked or funded with Alzheimer's Society an app that does a bit of cognitive testing and uses AI to interpret results that could help speed up diagnosis. So lots of interesting stuff, but to Katie's point, I think it's just taking that caution about digital exclusion and, you know, for people living with dementia, thinking about consent as well and ensuring that that's well managed. In terms of the question about the risk of inaction for carers, I mean, ultimately it's carer burnout, right? It's carers becoming overwhelmed, and we know that for people living with dementia, unpaid care is, you know, a massive, massive part of the picture. And then in terms of funding models, I'd kind of agree with what Katie said. You just have to consider everything. There are so many different solutions, and I think, you know, I mean, even fairly recently, there were conversations around the cap on care costs, for example. To me, and this is a personal opinion, not an organisational one, but it felt like that was moving in the right direction. But as often happens, these conversations get dropped as you know, government administrations change, and we can't let that happen. It has to be a longer term conversation.
So I guess the cost of inaction is that, you know, very large proportions of our population, even larger than now, spend potentially 20 years or more in poor health, as opposed to, you know, the 4 or 5 years that they might live in poor health towards their end of life in a really supportive system. So I'm off to Singapore in a second, and in Singapore that's their aim. People live as long a life as possible and as short a part of it as possible in ill health, and that's perfectly scientifically evidenced. Don't really know much about AI. I know it won't put my mum's compression sock on, so I still think that, you know, let's incorporate AI into intelligent redesign of human systems. And I don't know much about social care funding, except for every month I must pay my mum's social care, her domiciliary care bills, and I just think, you know, as important as how we fund it is how can we fund something that people actually want.
Again, AI, undoubtedly, I think we don't know half of it yet. It will develop, it will have opportunities and it will have risks. I'm not going to focus on that. I think on the funding, there are two things I'd want to say. One is at the moment, you know, I work in an organisation where we, for example, we showed the benefit of improving the quality of people's homes and the benefit that would bring to both the NHS and the social care systems. But they're different budgets. So our government works in silos. So you save money here, you spend money here, but you save it here. Nobody wants to know. So that's why I'm talking about joined up across government. Unless we find a way of doing that, no one's going to put their hand up and say, you can spend my money, because it will benefit somebody else, in their opinion. So I think that's absolutely crucial. Another one is, why don't we put unpaid care into GDP? At the moment, and I come back to this argument, that we kind of feel that care is not something that contributes to our economy. If it starts contributing to our economy, if we can see the payback it gives us, then investment will have a different implication. So that's two things I would say around the funding. And finally, cost of inaction. I think it's grim. I think, you know, we want to live in a country we can be proud of, but I fear if we don't do anything about the implications, I come back to the implications of the changing demographic. It won't be this generation or the next generation only. It will be the generation after that that are paying the price.
Brilliant. Unless there are any other questions from the audience, I wanted to ask a final question about mental health, which is, it's interesting that we have a lot of conversations about aging, and in some ways mental health is a bit exempt from that conversation. I know that's not true of people working in the sector, but I think often we think about care needs as being, again, bits of activity, physical help for people to live well. Wonder if people have reflections on the mental health component of this. How do we join up the agenda on reforming mental health services with the agenda on people aging well?
If I just say there's a consultation out, isn't there, for mental health strategy? And carers aren't mentioned once. And I think that tells you everything you need to know about that. So I'll be brief and just say that.
Yeah, I think it's a really interesting one for dementia because, like I said earlier, many dementia services fall under mental health service structures, but the challenge is that they're not really like other mental health services. And, you know, thinking about the consultation, I would say it's not necessarily built with that in mind. It's kind of thinking about mental health in a traditional sense. So yeah, I think for me it's about making sure that we're considering everything that falls into mental health services, including dementia. And then I guess just to speak briefly on, you know, the mental health of individuals that either are living with dementia or that are caring for people with dementia, there's also just a need, like I said earlier, to make sure that care is personalised and that, as well as really important pharmacological interventions and non-pharmacological interventions, you're doing things that are important to the person and that the care system is helping people do things that matter to them. One thing that we found in some work that we did recently is that cognitive stimulation therapy, which involves kind of reminiscences, etc., that you do in a group, it's a really cost-effective and clinically effective intervention that you can give people with dementia, but many services don't offer it, even though it's in the NICE guideline. So I think there's something there about making sure people can access the help that is sort of recommended for them.
So I think for many, many parts of the population, including many frail older people, but children and families, adults in crisis, you know, the fundamental mental health issues can be fixed through non-medical, non-technical interventions. So there's a fantastic organisation, Mosaic Clubhouse, over in Brixton. They take people with really quite significant mental health challenges and they focus on friendship, community, peer support, recovering agency and purpose in life. And certainly for the frail cohort that I'm focusing on in Hounslow and adults with physical health, mental health and social challenges in Hounslow, I think that's the thing we need to be focusing most on.
Yeah, I would agree. I think mental health is such an encompassing word too, isn't it? So if you're living in a home that's damp, cold, mouldy, your mental health is unlikely to be good. So it comes back to this joined up thinking and focus on the individual. The other thing I would say, and I come back to the ageism point, is that although we're talking about older people, we know that ageism is absolutely pervasive and probably all of us have it to some extent because we've grown up in this country where older people are not seen as, there's huge stereotypes about older people. And one of them relates to mental health, which is why probably if an older person presents with a mental health problem, they're much less likely to be referred for talking therapies and much more likely to be given drugs, even though there is not the evidence to support that that's the right approach. So ageism is another element here that we need to be looking at.
Brilliant. We are just about out of time, so I'm going to open up to closing remarks and perhaps some reflections on again, this conversation can often be quite negative and can often be about system in crisis and things that are going wrong. And I appreciate that that is often people's experience of services and experience of providing care. Would be lovely to end on a positive note about things that are exciting that are coming down the line, but also kind of slightly burning platform moment. What is the one thing that, if we could take nothing else away from this panel, that we'd like to, if we could take nothing else away from this panel, what we'd like to reflect on?
And I'll go first. I think there's something about having a bit of hope and community, and I haven't really spoken about We Care, which is advocating and amplifying voices of unpaid carers to decision makers. But in doing so, we've created a community online that support each other. We don't have a physical base, we're online, so we talk to each other every day, and there's lots of other voluntary organisations that do that sort of thing. But I think there's some hope there that there's power in us all being together, there's a bit of hope there, and it's just nice to find your tribe, whoever they are.
Yeah, I mean, I think it's so easy, like you said, Seb, to fall into kind of fatalism about these things, but like things can change. And for dementia, for me, what gives me loads of hope working in this space is that we're in a position now where in a few years' time, we could have a blood test on the NHS that tells you whether you have dementia. And, even further in the future, we may have a point where there are treatments that can, actually cure dementia. So for me, it's all about thinking about what we can do to drive us to that moment where dementia is truly a preventable and one day curable condition. What that requires, as I've said before though, is that focus on early diagnosis, because one of the things we see is that we don't have enough people that are diagnosed at the early stages in clinical trials, and it all cascades from there. You have good clinical trials with lots of people in the early stages, that teaches us more about the disease, and then the treatments get better, and that galvanizes the medical profession, and that galvanizes action. So yeah, for me, it's all about making sure people get that early and accurate diagnosis.
So in my area, primary and community care, I don't think there's any cause for pessimism. We have all the evidence we need to know what we need to do over the next few years. There are pockets of outstanding care around England, but more importantly, at larger scale, there are perfect functioning examples of really, really good team-based care for people with frailty and complexity around the world. All we need to do is be attentive and really learn carefully about how those systems work, and then do it here.
I've touched on it already. I think we've touched on this concept of relationship, and if Hilary were here, she'd be talking about that as well. And I think we're losing that. It's at our peril, really. So I think, as well as saying there's systems in government that we need to look to have, we also need to revalue that in our society hugely, and to work with communities directly. It's not all going to come from the centre. We know that. And there's great work going on, but everyone's struggling at the moment. So that gives me optimism, but it also gives me concern.
I'd like to thank all of our panelists for a fascinating and brilliant discussion, and particularly for persevering through the day. I know it is extremely hot in here, so thank you so much to all of you. We're going to have a brief break for furniture rearrangement before the final session, but please do say a huge thank you to our final panel of the day.
some water?
Yes, that'd be great, actually, yeah. I feel like I'm going for a little walk around a clinic.
Oh yeah, the doctor vibe, yeah. Okay. Secretary of State, welcome. Thank you for joining us for this fireside chat. We spared you the fire today. And thank you for making time for us. You've had a few weeks in post and you've got one of the most complex briefs in government. So I'd really like to start with your first impressions. What has surprised you and what did you expect when you arrived?
Thank you. Well, firstly, thanks very much for having me along. And I feel like if I tuck my tie in, I look like I'm about to go on a clinical walk around, don't I, like that? So it feels appropriate. What surprised me? So I think, if you think about what I've been doing before coming into this role, I was a councillor for 10 years, and then I worked at City Hall in London, and then the Treasury as a minister. And so delivery for me, working out how systems work on the front line, working out how, as politicians, we can transmit priorities through the system is something which I've been spending a lot of years doing and thinking about. I think one of the things that surprised me in terms of understanding how to do that in the health service and in the NHS in particular is how important some of the soft levers are to make that change happen. Because it's not anything new to say there's a range of hard and soft levers to make change happen. But I think the importance and the immediate importance of those soft levers from people who are senior in NHS England, from people in the regions, from the chief executives of trusts, from politicians as well, the messages that we send through the system have a more profound and immediate impact than I think I would have expected. So understanding that dynamic, I think has surprised me. And I realise how important they are to making sure that change happens.
What did that tell you about the biggest challenges that the system faces?
So I think one of the biggest challenges the system faces that I want to take on, and I've begun taking on in the last 6 weeks, is around transformation of the system. So I think the NHS is very focused, and rightly so, on the important targets we have as a government around waiting lists, around the 18-week RTT target, around urgent and emergency care. All of that focus is embedded in what the NHS does day to day. What I think we also need to do, though, for the health service is to transform it. And I'll give you what my top 2 priorities are in that regard. Firstly, the technological transformation. So making sure we're using all of the new digital options, all of the new AI tools that we can use in the NHS. All of that transformation needs to happen. The other one I would point to is around neighbourhood health, about shifting out of hospitals, out of GP surgeries, into local areas, local neighbourhoods, so that GPs can work with community services, with local councils, with other providers of health care and support to make sure we've got that preventative healthcare system that we need. I think both of those transformations need real energy politically. They need energy from the Department for Health and Social Care, energy from me and my ministerial team to make sure that happens, because otherwise a lot of people working in the NHS are absolutely rightly focused on meeting those targets, on delivering for patients, on making sure that service is provided even when we face lots of challenges along the way. To transform it at the same time, I think is where the political leadership can really add to what we're doing.
Thank you. And you started to cover some of this already, but you were very clear when you took the job that what was needed was not a change of direction or a change, but a change of gear. What does that look like to you in practice?
So I thought it was really important for me to say that quickly to the system, because going back to my earlier point about the importance of the soft levers and about the messages being transmitted through the system, I didn't want everyone working in the NHS to take their foot off the pedal and sit back for weeks or months whilst we consider if we want to change what our targets are or change what our priorities are. So I made very clear that the 10-year health plan is a plan of this government, of this Labour government, taking over as Secretary of State. Those are my targets, that's my priority. I want to focus on that as well, and I don't want to waste a second of people sitting back and not focusing on meeting those targets and those priorities. But I think I also recognise that if you look at the progress over the first 2 years, that's been on the back of record investment, massively increased investment over the first 2 years, and a real focus on performance management and technical efficiencies right across the NHS. And that performance management has been critical to driving up performance in the first 2 years. Really impressive increases in performance, which should give NHS trusts across the country real confidence that we can do it, that we can really improve what we're doing and move forward. But I think that performance management won't get us to the position we need to be in a few years from now. So I think what we need to focus on in the coming years is that shift of gear when it comes to transformation. So in terms of using technology, digitization, the use of AI, transforming the way the systems operate in the context of all that new technology so that we make it more efficient, more focused on patients, is what needs to happen now. So the first 2 years of this government have been about increasing the investment, about boosting performance, about getting the whole system to work together around those goals to make that sustainable and to go much further, which is what we need to do in the coming years of this Parliament. That's where transformation comes in, and that's what I'm leading on driving.
And partly, you've been very clear that transformation comes through allowing the front line to innovate. How do you give people on the front line genuine freedom to innovate in an environment that is sometimes high risk and also where you need to deliver politically?
Yeah, and there's a really interesting dynamic that you allude to there between having a strong centre giving direction, but also having the freedom and independence for the front line to innovate across the country. And the way that I would see that as working is firstly, at the centre, I need to make sure that people working across the NHS know that if they innovate, where they innovate, I have their back. That I want to see that innovation happening, that I want to see people on the front line taking the appropriate level of risk as well. Not risks that obviously puts anyone in a difficult position using the NHS, but risk in terms of trying new innovations that might not always work, but we have to take that risk if we are going to try new innovations. That's part of the deal, I think. That's part of the relationship where the message from me and from people working in the Department for Health and Social Care and NHS England is that taking that innovative approach is what we want to see happen. I think we then have a role at the centre of saying when we see really good innovative approaches or new technologies or new systems built around technologies at local levels, we will support them to be spread across the whole system. And that way we can use the centre and the front line in a kind of positive feedback where we give the front line a cover to innovate and we then help the front line innovations to spread across the system.
And you've spoken at length about the power of technology. What do you feel are the constraints within that? Is it capital investment? Is there cultural elements that stop you from making the progress that you'd like to? What are the challenges within moving that forward and implementing?
I mean, I think the biggest challenge is twofold. Firstly, spreading those innovations right across the system. I think we know what kind of innovations we want to make in terms of technological changes in the immediate future. Spreading them across the system is the first challenge that we face, and we want to make sure that happens. But then I think the more profound issue which we need to confront, and which is important to making the best of any technological innovations, is to make sure that trusts and providers right across the country are reshaping the way their services work, reshaping the systems around the new technology. And what I mean by that is that if you have healthcare being delivered in a certain way now, and you just layer on top a new technology, That might have some benefits. You know, it might have some improvements to the service which is being provided or make it more efficient in terms of productivity, but it will miss a lot of the really big productivity gains that you could gain from transforming the service around that technological innovation. And that's actually the harder part, because I think if you just layer a new technology on top of business as usual, you'll get some benefit. Thinking about how business works and restructuring that around the new technology, that's the harder part, but it's where the really big gains can be made.
And in your view, is that the main route to productivity gains? What are the other elements that you feel will support that transformation?
Yeah, I think productivity gains from technological change are the really big prize in front of us. We can see, if you look at how AVT, ambient voice technology, is working in so many places across the country, really significant reductions in time clinicians are spending on the front line, having to make notes, a real increase in the time available for them to speak to patients, increasing the rate at which they can speak to patients across their shifts. That's a good example of a technology where the productivity gains are really significant. But actually, to build on my earlier comment, if we simply layer on AVT across the health service, we will make productivity gains. But if we start thinking how we can reshape the service around it, that's where the even further gains can be made. And one of the first things I did in this role was the second reading of the NHS Modernisation Bill, which is going through Parliament at the moment. And that includes the enabling legislation for the single patient record. Now, the single patient record is a good example of a technological change, a digitisation of records and making connections between the records, so records across the system can all be seen from one place. If we just do that, there will be benefits, because it means that we don't all have to tell different healthcare professionals the same story multiple times. It means that things are much less likely to be missed, because any clinician can see records from the GP surgery, from various different hospitals and so on. But that infrastructure of a single patient record then allows you to build really big changes on top of it by changing how the system works around that connection of data. And that's where the next stage of productivity gains and better delivery, I think, lies.
Thank you very much, Secretary of State. We've got just a little bit of time now for some questions from the audience.
Great, thank you.
I'll take one over there. One from there and one from over there. Over there first, thank you. Yes.
Hi, Sean Muller from Daily Mail. So we can get an idea of the timescales you're working to. Do you expect or want to be Health Secretary under Andy Burnham? And then secondly, looking at the Ockenden review yesterday, you've said that you will compel future leaders to engage with inquiries or they'd risk a prison sentence. Can you commit to draining the swamp of those that have refused to engage with previous inquiries or are responsible for failings in the health service, and then fire those that still remain?
Well, thanks for your questions. And on your first question there about Andy Burnham, I'm backing to be the next leader of the Labour Party and to be the next Prime Minister. I know that he's got an amazing track record in Manchester in terms of health, as well as in terms of public transport and growth and investment. And I know he'll bring that drive and that focus to his work in Downing Street. Obviously, any decisions about cabinet or other ministerial posts for him to make wouldn't be for me to make suggestions to him in that regard. But I'm loving doing this job, and I've made sure that getting into it, we haven't lost a second in terms of pushing forward with our agenda of delivering better services and better NHS for patients, and making sure that we're driving that transformation which I've been speaking about today. On your second question about the Ockenden report, which was published yesterday, last week I went and met a small number of the affected families in Nottingham, and it was incredibly hard for them to relive their trauma, to share their stories with me, having shared it so many times before. I found it numbing to listen to their pain, and then, as I said in my statement yesterday, to then recognise that their pain is multiplied so many times beyond. Some of the priorities of the families I spoke to are around change, around changing the way maternity and neonatal services work, but also around accountability. And that's why the issue around accountability and senior clinicians not taking part, not giving evidence to Donna Ockenden's review, I think is so unacceptable and has caused so much upset to the families involved. And so that's why I committed yesterday that we will implement the duty of candour, which will be brought in by the Hillsborough Law when that's in legislation. We will apply that to maternity reviews in the future, so that when maternity reviews happen, for instance, the two which are coming up in Leeds and Sussex, people will not be able to refuse to take part in that, because I don't ever want to have a situation again where NHS staff, past or current, can refuse to take part. They have to take part to make sure we can get that accountability and justice that families deserve.
Thank you. We'll take a question from over here, and then two from over there. We'll take them in threes.
Hi, thank you, and thank you for taking on the job, you know, and getting to grips with it so quickly. I'm Jenny Edwards from the People's Health Trust. The government set this amazing and impressive ambition of halving the health inequalities that currently are 20 years of healthy life expectancy. How do you think we're doing? And what do you think is most important in doing that? Just to add on to the end of that, and will you engage with communities who know a lot about what that means to those lives and the communities that are blighted by it?
Thank you. No, thanks for that question. And I think, sorry, do you want me to
No, it's fine. I could take a couple more, and then maybe you can...
okay, sure, yeah.
Just lady over there, please.
Hi there, I'm Alex. I work for Alzheimer's Society. My question is about avoidable hospital admissions. So 1 in 6 people in a hospital bed have dementia. With your both DHSC and Treasury hat on, I wondered if you could speak to what more can be done to kind of unlock cost savings from preventing avoidable hospital preventing avoidable hospital admissions. Thank you.
We'll take this.
I'll take those two, sorry. I was making a list so I don't forget them all, but I can just about remember those two. So on the question about health inequalities, one of the things that has really struck me about getting into this role is the degree to which health is determined not by the NHS, but by everything else in life. And it's a real privilege to sit down with Chris Whitty, who explains all of the statistics and all the data around this and shows just how much different factors in people's lives impact on their healthy life expectancy and on the likelihood they have of having various diseases or illnesses throughout their lives. So I think for me, the shift in the 10-year health plan from illness to prevention, making sure we're preventing people from getting ill in the first place, is absolutely crucial to making sure not only that the NHS is sustainable in the future, but also to truly improving the nation's health. Because the NHS is such an important thing for all of us that quite often discussions around health talk just about the NHS, but really there's so much more we can do in terms of preventing people, helping people prevent themselves from getting ill in the first place, and that's where I think a lot of those questions that you're raising are most important. I think there's also that question of equality, because we know that in terms of healthy life expectancy, in terms of access to different good quality food and all the different determinants of people's lives and their healthy life expectancy, that varies a lot by different factors in society. And so as well as being a health question, it's also an equality question more generally. So I really think that my vision of how we should make the population healthier is by thinking not just about the NHS, as absolutely central as that is, but it's also about how do we prevent people becoming unwell in the first place, and really take a step back and think about, well, what about bad housing? You know, what about air quality? What about mental health if people are out of work? You know, we should get more people into work so they have better mental health. All those kind of parts of people's lives are really important. And some of the structures which are coming in through the legislation that's going through Parliament at the moment will help with that, with ICBs being more closely connected with mayoral authorities, who then have remits over housing and transport and so on, to try and have that link up between the wider determinants of people's lives and health, rather than just the NHS and health, I think is the way to tackle the issue that you raised. And then on the question about avoidable admissions to hospital, you know, I think when we talk about social care, we quite often think about people who are living in either a residential social care setting or they have social care coming to their home and looking after them in that way. The other part of social care for me is to try and make sure people have that help when they need it to prevent them going into hospital. And that's the part for me that can help not just the people who are directly affected by frailty or by illness, but it can also help take some pressure off the NHS. So for me, that focus on social care and neighbourhood healthcare, trying to help people avoid going into hospital in the first place, is really critical to taking that pressure off. I often think about it as a sort of upstream and downstream, either side of hospital. Upstream, we want to prevent people going into hospital in the first place. Downstream, when people have been attended to in hospital, want to make sure they can leave easily and they have the care they need to do so. So that's why my focus on neighbourhood healthcare that I mentioned at the beginning is so important, because if we can help particularly people who are frail or elderly from needing to go into hospital in the first place, that's a huge benefit for them, but also for the NHS.
Thank you. So we've got time for just 2 more questions. I'm going to go right to the back over there, lady, and I'll take one from over here, please.
Hi there, it's Lauren from the social innovation charity Nesta. My question is, the 10-year health plan was published. I think we're nearly at the year mark now. I think it's very, very soon. And within that, there was a commitment to end the obesity epidemic within that. I was wondering kind of what your plans are to kind of push that forward, get those commitments out there, because we're yet to see kind of much progress on some of the commitments that were in that.
And the gentleman over here.
Thank you. I'm Eric Salem, Director of Policy at GSK and formerly DHSE and Treasury as well. Just building on what you were saying before on prevention, I'm really interested to get your thoughts on, I think the macroeconomic case for investing in prevention and population health, it's been well think tanked and there's lots of evidence out there now. What, in your view, is the way to kind of make this a whole of government priority where, say, the Treasury and the OBR really believe, this is really, and this can really move the economic and fiscal position? They've seen use cases and opportunities, I think, around talking therapies where that can make a real difference. So how actually do we get this belief in the centre of government to really sort of help drive this in the way they allocate resources as well?
Great, thank you. Well, thanks very much for both those questions, and in a way they link together because if we can tackle obesity, that's one of the key ways of helping to prevent people from being unwell in the future. And I think it's a right for you to say, look, we need to make sure this is a whole government approach, because it's not just about the NHS, or it's not even just about the Department for Health and Social Care to make sure we're helping people to live healthier lives. It includes, as I said earlier, housing. It includes people being able to get into work. It includes people eating more healthily. So I think the prevention agenda is one that we have to address as a whole government, and not just at the national level, by the way. I think one of the really big benefits we can make in the coming years is to focus on devolution and giving more power to local areas where healthcare is delivered, but also where some of the other determinants of poor health, like poor housing, or like people being unemployed, or not having access to open spaces where they can go out and have exercise. All of those are really local issues as well. So I actually think the devolution agenda links up very well with the preventative agenda. And I'm someone who, I come from a background of 10 years as a local councillor and then nearly 4 years working at City Hall in London. And I felt then that at the local level, there is a lot more understanding of how to improve people's lives through the determinants of what can have an impact on them, whether that's their housing or their job prospects and so on. Some people said to me, well, once you're a national politician, you'll forget all that, won't you? But I can say absolutely I haven't. I think it's ingrained in me to focus on that devolution, to have that power going down to people on the front line. So through what we're doing in the NHS modernisation bill, with more power at ICBs, and with ICBs then being linked up with mayoral strategic authorities, and with that focus on the wider determinants of health, I think that's where the preventative agenda has great gains to make.
Thank you very much, Secretary of State, for your time and insights. I think that's a wrap-up for the amount of time that we've got with you today. So thank you very much for your time. Thank you very much for your insights, and
thank you.
Thanks for all the work that you've done so far.
Thanks very much. Thanks for having me along. Thank you. Thank you.
Thank you, everyone. So all that's left is, for me, Harry Corsman, I'm the Director of IPPR, to say thank you to everyone for joining us today. I know our chair, Victor, kicked us off. I'm less knowledgeable on health than him, less handsome, less charismatic, so probably a bit of a downgrade, but nonetheless, I'm delighted to be here, and I'm delighted you've joined us today. I'd like to thank all our keynote speakers and our panel speakers, who are all excellent. I'd like to thank our events team, particularly Holly, for stewarding today's event, and to Seb, of course, our head of health, who has put today's programme together. And also to our sponsors, so AbbVie, the British Heart Foundation, Gilead, Haleon, MSD, and Sandoz. Without the support that those organisations provide, we wouldn't be able to do the work we do. We've had a really interesting set of debates here today, and I think they point to the fact that whilst we're seeing some significant progress in the NHS, with waiting times coming down, and with a 10-year plan which sets out a kind of bold, clear trajectory looking forward, there is still so much work to do, and there are still big gaps that need filling. And in particular, the thing that I was struck by in the conversation was how many of the things that we're talking about we know will deliver better outcomes, so they might deliver better patient satisfaction or more coordinated care, but which we are claiming will also solve a productivity and a funding problem in a fundamental way. And I think it should be increasingly clear to us that whilst they're the right things to be doing, that they're not going to solve the scale of the challenge we're facing. So prevention is the right thing to do, but very rarely does it lead to an outright funding saving, because people get sick later, and different sickness later on in life. And that's a good outcome. It's the outcome we should be aiming for, but it's not going to save us huge amounts of money. And similarly, technology, absolutely fantastic and can definitely relieve lots of pressure on the front line. But as we get new treatments and new technologies, they also require investment, and they often expand the scope of what healthcare can deliver, which again is a great thing, but doesn't always lead to the savings we want. So I think one of the debates that IPPR wants to make sure that we are putting top of the agenda in the coming months and years as part of the sense of health and prosperity is being really honest with ourselves about whether these things are going to be transformative in outcomes, and they should be, but also whether they're going to solve the funding challenge and the productivity challenge that we face in the NHS and social care. And if they're not, what trade-offs are we willing to take? Is it that we want to put more money into the system, or is it that we want to decide what the system should be delivering and be a bit more ruthless about that? Because without those hard choices, I worry that we continue to tell ourselves a fiction about what the reform agenda that we are pushing is going to deliver. And so I would encourage us all to take away the kind of key messages of today, and to join us at IPPR on the journey to try and think through some of those big challenges. It is now getting increasingly warm in the room, so I'm going to suggest that we decamp to the room behind us, where there will be some refreshments. But thank you, everyone.